from a pain-free experience and reduced radiation exposure, ensuring patient-focused care. The Gamma Knife Esprit also shortens treatment duration, making it a convenient outpatient procedure. With its advanced capabilities and unmatched precision, the Gamma Knife Esprit offers hope to patients facing challenging brain tumors. Experience the future of brain tumor treatment at Fortis Hospital, Gurugram.
I'm standing in front of the latest generation of the Gamma Knife Esprit in this part of the world. It is a machine which is of extremely high precision to treat patients with very focused radiation. This device has a background of evolution by a neurosurgeon who had designed the concept of stereotactic surgery. It initially started with the Lexel frame, and the name goes by the person who invented it, which is a very precise technique of reaching targets in the brain for very precise operations. This evolved into this device, which is also based on stereotaxy, which is using XYZ coordinates to reach with great precision radiation beams where it is required. This precision is at the level of 0.2 millimeters, which is far more than any other device which is delivering radiosurgery. This is a device which has been invented by a neurosurgeon and is essentially a neurosurgical tool. And it is very important to realize that because we use this as a part of our armamentarium. So whether we're operating or we're doing this particular treatment, the whole idea is to achieve a cure in a lot of diseases in the brain. And it is a balance of these two procedures where we can achieve this goal. Sometimes we use this alone as a primary and only treatment. A lot of times we treat it as a part of the whole treatment, which is surgery followed by radiosurgery. So we use this device for a lot of benign tumors and more for secondaries in the brain. It is an extremely precise device for secondaries in the brain, and we can treat multiple deposits in the brain, and more it becomes a very important strategy for treating secondaries in the brain. One of the main goals of neurosurgery is to try to cure with the utmost safety. When we combine these two parameters, it becomes a conflict sometimes, because the more we try to remove the disease, the more we are making it unsafe. So this new device is something which we use to balance and yet achieve a cure. The balance is by trying to remove surgically as much as possible, and where we feel that the risk is very high, we would treat the rest of the treatment by this device. Adjoining at that area, for example, the nerves related to the eyes, which are very sensitive to radiation. So the goal of surgery then is to try to create a situation where these sensitive structures are as far away from the residual disease, and also the volume of the disease is reduced to the very minimum.
So dear friends, you have been listening for last few months about the launch of our new Gamma Knife. Now the time has finally arrived when the new Gamma Knife Esprit, which is the first of its kind in South Asia, has been finally launched. As you all know, Gamma Knife is the latest technology and the best technology in the world to treat brain tumors without any surgery. So Gamma Knife can treat both benign and malignant brain tumors of various kinds. It can also treat non-tumorous conditions like arteriovenous malformations and trigeminal neuralgia. You are most welcome to visit our Gamma Knife facility to see the latest technology which can treat the brain tumors without any surgery.
Introducing a cutting-edge innovation in the landscape of neurosurgery, the Gamma Knife Esprit, now available at Fortis Hospital, Gurugram, marks a revolutionary leap forward in brain tumor treatment. This state-of-the-art technology utilizes precise, non-invasive radiation to target brain tumors with unparalleled accuracy. Our team of expert neurosurgeons at Fortis Hospital, Gurugram harnesses the power of the Gamma Knife Esprit to provide patients with a safer, more effective alternative to traditional brain surgery. With a non-surgical approach, patients benefit from a pain-free experience and reduced radiation exposure, ensuring patient-focused care. The Gamma Knife Esprit also shortens treatment duration, making it a convenient outpatient procedure. With its advanced capabilities and unmatched precision, the Gamma Knife Esprit offers hope to patients facing challenging brain tumors. Experience the future of brain tumor treatment at Fortis Hospital, Gurugram.
I'm standing in front of the latest generation of the Gamma Knife Esprit in this part of the world. It is a machine which is of extremely high precision to treat patients with very focused radiation. This device has a background of evolution by a neurosurgeon who had designed the concept of stereotactic surgery. It initially started with the Lexel frame, and the name goes by the person who invented that device, which is a very precise technique of reaching targets in the brain for very precise operations. This evolved into this device, which is also based on stereotaxy, which is using XYZ coordinates to reach with great precision radiation beams where it is required. This precision is at the level of 0.2 millimeters, which is far more than any other device which is delivering radiosurgery. This is a device which has been invented by a neurosurgeon and is essentially a neurosurgical tool. And it is very important to realize that because we use this as a part of our armamentarium. So whether we are operating or we are doing this particular treatment, the whole idea is to achieve a cure in a lot of diseases in the brain. And it is a balance of these two procedures where we can achieve this goal. Sometimes we use this alone as a primary and only treatment. A lot of times we treat it as a part of the whole treatment, which is surgery followed by radiosurgery. So we use this device for a lot of benign tumors and more for secondaries in the brain. It is an extremely precise device for secondaries in the brain, and we can treat multiple deposits in the brain, and more it becomes a very important strategy for treating secondaries in the brain. One of the main goals of neurosurgery is to try to cure with the utmost safety. When we combine these two parameters, it becomes a conflict sometimes because
Good evening.
the more we
May I
try
request,
to
can we please turn the volume low on the video? Thank you. May I request everyone to please find their seats? We should be starting in the next few minutes. 5 minutes, please, of which we have lost one already. I know it's absolutely wonderful to catch up with everyone, but please do find your seats. May I request my colleagues at Fortis to kindly request people who are standing outside to make their way in. Have for the sessions later. We might have to start using it right now. Please do find your seats.
Doesn't need any introduction.
Hi. Do find your seats, please. Thank you. I know this is Professor Banerjee is here and I totally understand, but we're going to have time later as well. Sure. Yeah? Thank you so much. And our 5 minutes are up. I used to be the monitor in school. I'm getting that feeling all over again. Dr. Amal, you know where your seat is? Wonderful. Okay, here we go. In the summer of 1910, Dr. William James Mayo delivered the commencement address at Rush Medical College in Chicago. In his speech, he said, and I quote, "The best interest of the patient is the only interest to be considered, and in order that the sick may have the benefit of advancing knowledge, a union of forces is necessary." Over 100 years later, as we introduce the Gamma Knife Esprit, Fortis Healthcare upholds this principle by merging our neurosurgical expertise with the latest such technology available in South Asia. This union promises new avenues of hope and precision for patients confronting brain tumors and neurological challenges, ensuring they receive the best care possible. Good evening, distinguished guests, senior clinicians, esteemed colleagues, and friends. On behalf of Fortis Healthcare, led by the visionary Dr. Ashutosh Raghuvanshi, I extend a warm welcome to all of you. Fortis Healthcare has always been at the forefront of medical innovation, and today's event is a testament to our commitment to excellence. My name is Nikita Singh, and it is my absolute honor to be your host for this historic evening. We are delighted to have with us two stalwarts in the field of neurosurgery, Professor A.K. Banerjee and Professor V.S. Mehta. Their pioneering work has paved the way for numerous advancements in medical science. Next, it gives me immense pleasure to introduce Mr. Anil Vinayak, our Group Chief Operating Officer of Fortis Healthcare. Under his leadership, Fortis has not only achieved clinical excellence, but also touched countless lives with compassion and care. It is my privilege to introduce Dr. Rana Patil, Chairman of Neurosurgery at Fortis Gurugram, whose contributions to the field are not only commendable, but also unmatched. And Dr. Sandeep Vaishya, Executive Director and Head of the Department of Neurosurgery at Fortis Gurugram. Dr. Vaishya's distinguished career and expertise will provide us with a comprehensive understanding of the advanced technology of the Gamma Knife Esprit. Finally, I would like to acknowledge the presence of senior clinicians, eminent colleagues, and important members of the healthcare industry who have traveled from across India and abroad to be here with us today. Your presence highlights the significance of this launch and the transformative impact it will have on patient care. To officially commence our event, I invite on stage Dr. Sandeep Vaishya to deliver the welcome note. His remarkable career and contributions to neurosurgery are well known, and we're eager to hear from him. Dr. Sandeep Vaishya.
Good evening, everybody. Respected Professor Banerjee, Professor Mehta, Dr. Mishra, our honored guest, Dr. Dhiren Prasad, Mr. Anil Vinayak, CEO of Fortis Group, and dear colleagues. We all have gathered here today for the CME on radiosurgery, which has been held to celebrate the launch of Gamma Knife Esprit at Fortis Hospital in Gurgaon. I welcome all of you to this meeting. It is a great honor for me that my respected teachers, Professor Banerjee and Professor Mehta, are here to bless the occasion. Everything that I learned in neurosurgery was from them only. I am particularly indebted to Professor Banerjee, who has taken the trouble to come here when he doesn't go out much these days. I'm sure, sir, half the people have just come to meet you only. Dr. Dhiren, it has been an amazing 2 weeks that we got to spend with you and learned so much, and hope to continue our collaboration and research further. I welcome all our guest faculty and participants who have come from various parts of the country, taking time out from their busy schedule. I started doing Gamma Knife at AIMS in 1997, and when I left in 2006, I continued at WFNS till 2014, I think. So for 17 years, I worked on Gamma Knife B model. Now, an upgrade to Gamma Knife Esprit seems like a quantum leap, and I'm just amazed at the capability and versatility of the new machine. We have already treated 15 patients in the last 2 weeks, and I was just amazed at the way we treated them. I'm sure we will enrich our knowledge by today's CME on radiosurgery. In the end, I would like to welcome all the people from embassies, corporates, and healthcare partners. Thank you.
Thank you, Dr. Vaishya. I now invite Mr. Anil Vinayak, the Group Chief Operating Officer of Fortis Healthcare, to address the gathering.
Thank you, Nikita, and a very warm welcome to everybody here today. Good evening, ladies and gentlemen. Thank you for joining us on this very special occasion for us. The launch of the first Gamma Knife Esprit in South Asia at Fortis Hospital, Gurugram, is indeed a very, very special milestone for us. At Fortis, we are committed to bringing the latest technologies to support our clinicians in providing the best possible international standards of care to our patients. We are absolutely passionate about improvement of patient outcomes as well as their quality of life. And I think this today is a reiteration of that commitment. Today's journey is the culmination of almost 2 years of very, very hard work by a lot of people that are today in this room and many who are not even here today. I can't mention all of them, but I must mention the 2 neurosurgeons here whose passion, vision, and commitment to making this happen is really instrumental for us being here today. Dr. Rana Patir and Dr. Sandeep Vaishya. Thank you, sirs, for showing the confidence that we could bring a technology of this kind and make it successful here in India. I'm sure a lot of patients will benefit from this, and the academic calendar today is quite packed, so I will cut short my remarks, and thank you very much again for being here. We look forward to an interesting evening. Thank you.
Thank you, Mr. Vinayak, especially for your unwavering commitment to advancing healthcare through Fortis in India. I now invite Professor A.K. Banerjee, who is a trailblazer in neurosurgery, to share his thoughts. His contributions to the field have been monumental, and we are honored, beyond honored, to have him here today. So you'll have to guide me. Should we organize a mic where you are? Perfect, we'll do that.
Thank you. Well, friends, it's a great occasion for Fortis, and for me, it is a double pleasure seeing that we have two of the very young people who were once at AIMS, Dr. Rana Patir and Sandeep Vash, who are piloting this project. I think 96 was the first gamma knife which came to Bombay or Mumbai, and we have Dr. Basant Mishra actually here. And since then, it's a little less than 3 decades. There are only 5 cities, including Gurugram, Chandigarh, Gurgaon, Delhi, Bombay, and Bangalore, where we have been able to install the machine, which is certainly extremely versatile. And I would like to wish you all success. And I think credit goes to the managers of Fortis who have thought of it, because it's not only something which is by itself great, but more important, it will attract many more people, not only in this specialty, but other specialties to the hospital. So that's, I think, the great thing. And of course, we have the enthusiasm, youth, and zeal of Dr. Rana Patir and Dr. Sandeep Vash. To both of them, I would like to thank, and especially Sandeep, because he had bribed me at a very crucial juncture when COVID was at its height, by giving me a Netflix. And so that was a debt of honor. So, you know, that I had to repay. Thank you.
Thank you so much, Professor Banerjee. Your words were really inspiring to hear, but I think my favorite part was the last. I don't think any of us are forgetting that in a hurry. May I request Mr. Anil Vinayak and Dr. Rana Patir to kindly step in front. We would like to felicitate Professor Banerjee with a small token of our appreciation. Mr. Vinayak and Dr. Rana. Dr. Sandeep, why don't you join in that picture as well? Thank you. Thank you, Dr. Rana. Thank you, Anil sir. Next, I would like to invite Professor V.S. Mehta, another stalwart, to address the audience.
Thank you very much for inviting me, Dr. Sandeep, Dr. Rana Patir, respected Dr. Banerjee, Mr. Vinayak, Dhirendra, Basant. Well, as far as Rana Patir, I must say that he has always been very innovative. When he was at AIMS, we always used to see he will develop some new equipment, some new instrument, which will be very helpful in our surgical practice. As far as Sandeep is concerned, I know that when he was appearing for his MCH course in Gwalior, I was his external examiner. So after examining him, I selected him. Till that period, I didn't knew that he is son of Dr. Andy Wesh. I only came to know in the evening I met him. Then I came to know that he is son. I said he has done brilliantly and he has been selected. Similarly, when he came to the AIMS, I was the selector, and then for, of course, in his course of becoming faculty and all that, then came Gamma Knife, and then we and VP Singh went to the Stockholm for training, and then he continues to work on a Gamma Knife. Now we all know that Gamma Knife is, or in aspect in neurosurgery, the accuracy and precision is the most important. Without that, no neurosurgeon can be successful, and similarly, no radiosurgery can be successful. There are a lot of competitors of Gamma Knife, CyberKnife, Linac. Now there is a new one, what called as ZPAC, or what? Zapex. But I feel that as of today, unless you are very accurate and precise, you cannot be successful. So for neurosurgery, the Gamma Knife is the standard of the treatment in many situations where you need to spare some of the important structures, and that can be possible by only Gamma Knife. And as we all know that today the public is knowledgeable, they know the information by the means of Google, but Google information is not complete. This half knowledge. So one has to learn that the accuracy and the precision is the most important in neurosurgery, and I'm happy that the Fortis hospital has obtained this equipment or instrument for the care of the patients, and I'm sure a lot of patients are going to be benefited by this, and I wish that the Sandeep and Rana Pathe would have a good time for the success of this Gamma Knife. Thank you.
Thank you, Professor Mehta. May I request you to just stay back for a moment, please? I would like to invite to the front Dr. Bishnu Panigrahi and Dr. Sandeep Wesh to please felicitate him and present him with a token of our appreciation. Thank you. I'm going to be requesting some of you to step right back because now we are going to proceed with the ceremonial lamp lighting. This traditional ceremony will symbolize the light of knowledge, of course, and the bright future of medical advancements that the Gamma Knife Esprit represents. So may I please call to the front. I'm not going to call to the front, so I'm going to request all of my team here, can we move the lamp a little towards where Professor Banerjee is, so that it would be convenient for him to join in the lamp lighting. Of course, joining us for the lamp lighting are going to be Dr. Mehta, Dr. B.K. Mishra, Dr. Dhirendra Prasad, Mr. Anil Vinayak, Dr. Rana Patil, Dr. Sandeep Vaishya, and of course, Dr. Vishnu Panigrahi. Requested that we would be having a photograph with all the clinicians, the entire group. Are we doing that at the moment? Or should we schedule it for later? Okay, later then. All right then. We now move on to our very first scientific session of the evening, gamma knife radiosurgery and neuro-oncology. This is going to delve into the remarkable applications of the gamma knife in treating various neurological conditions. The session will be chaired by the distinguished Professor A.K. Banerjee, Professor V.S. Mehta, and Dr. Rana Patil. I am very pleased to introduce our speaker, Dr. Dhirendra Prasad, who is a world-renowned expert in gamma knife surgery, Professor and Medical Director of Radiation Medicine at the Roswell Park Cancer Institute in New York. Dr. Prasad, we eagerly await your talk. I know Professor Banerjee would keep sitting here. Would Dr. Mehta and Dr. Rana like to step onto the stage, please?
Start. Good evening, everybody. Respected Professor Banerjee, Professor Mehta, and all my distinguished colleagues, Dr. Basant Mishra, Dr. V.P. Singh, Rana, and of course, Sandeep, the powerhouse who's trying to do 300 things every day at the same time. Somehow we've had a wonderful 2 weeks getting the things going, and I'm happy to report that we are totally ready for full-scale launch of the gamma knife Esprit at Fortis. I think we've already done 15 cases in the last 2 weeks, so it's great to know. Without much further ado, my 30-minute charge is to try to take those who already know a lot about radiosurgery through some of the newer things that we're thinking about, and those who don't know what radiosurgery is get a brief idea of what this is all about. I work at the Roswell Park Cancer Institute in Buffalo, New York, in collaboration with UB, University at Buffalo, and Jacobs Institute, which is our innovation hub. And so a lot of what you see will be across these 3 different institutions working together. Nobody works alone. Of course, I don't either. We have a huge team of people, neurosurgeons, radiation oncologists, some of us confused like me who are more than one, and then medical physicists and pathology, nursing, and neuroradiology. This is a huge group. No man alone, said Wilder Penfield, ever achieves anything. And I have to acknowledge those giants on whose shoulders I have stood to get here. This picture is also very interesting, because if you think I've had a lifelong love affair with gamma knife,
Actually, it was an arranged marriage. And that was arranged between Dr. Banerjee and Dr. Steiner. He reported, I was working with Dr. Steiner. A year and a half later, he came to Bangalore, came back to me and said, I spoke to Dr. Banerjee, and he said, I can hire you. So there I was, in a part of a lifelong affair with radiosurgery. I also want to briefly recognize Danny Lexell. His father, Lars Lexell, is the one who designed the Gamma Knife, and we lost Danny last year. He was an ENT surgeon and one of the best advocates for the Gamma Knife for his father. In fact, his very first talk outside of Sweden about the Gamma Knife was in New Delhi. I've been doing this for far too long, 30 years, nearly 15,000 cases in my personal series. Every possible indication you can think of, I have done. But it started with a neurosurgeon, and that's how I ended up in radiosurgery. Lars Lexell came up with the idea in 1951 that we could actually use a high energy source of some kind to pinpoint and treat lesions inside the brain. At that point, he was thinking of functional neurosurgery, but of course, tumors were not far behind and vascular malformations. We changed the definition around to inducing physiological effects because sometimes, like in trigeminal neuralgia, we don't actually destroy anything, we modulate the function of the nerve. Lexell was driven to this because back then neurosurgery looked like that, and the stereotactic frame looked like the picture on the right, neither of which were very satisfying and honestly very difficult to imagine compared to what we do today. So he invented the modern stereotactic frame, the Lexell frame, and even though he was not a radiation oncologist, he came up with the idea of a device that actually had the concept of an isocenter built into it, which means you point from any direction and you hit the same point inside the brain. And so very quickly he adapted it to apply orthovoltage X-ray tube and treat the first trigeminal neuralgia. He even looked at proton beams and linear accelerators, but fundamentally found those techniques and platforms to be far too complicated and not quite ready for prime time. So he designed a dedicated device using cobalt-60. At that point, there were 183 beams concentrically focused at one point. Then it went up to 201, and the current iteration is a multiple of 8 and uses 192 beams. But the principle has not changed. Cross-firing very finely collimated pinpoint beams into one spot allows us to actually achieve very high precision and a very tight focus, which we will talk about. Here is Professor Lexell with Christer Lindquist. In the early phase of the Gamma Knife, we used to apply the frame on a plaster cast. Modern day Vantage frame is a huge, very long walk from there. And that's the original lesion that was produced. It was a 4 by 3 millimeter lesion, not a circular lesion, because back then Lexell was trying to cut fiber tracts in the thalamus and interrupt pain fibers, which was his primary goal. Subsequent Gamma Knives all come with quasi-elliptical or almost spherical collimator that produces a spherical dose concentration in the brain. Contrary to what a lot of commercial advertising might indicate, the Gamma Knife is not static, it's not obsolete, and it's never going to be yesterday's news. In fact, if anything, it has a firm place in radiosurgery, and over all of its evolution, some things have remained very, very identical. The big steps came with perfection when a lot of robotic-style automation and automatic positioning was included, and then the next big evolution was the Icon, where onboard imaging and the use of a mask permitted hypofractionation. The Esprit, which is now the latest model, redesigns many of the control components. It changes the entire patient control or positioning system, upgrades all the controlling servos to make us ready for the next evolution in radiosurgery, which will be basically dose painting. And when that happens, Esprit will be the platform on which it will be rolled out. And the console has been also changed to make it operator friendly and more foolproof. There's lots of changes that have come. Very similar in appearance to the Icon, but worlds apart in terms of what it's intended to do. And ultimately, any Gamma Knife center looking to get along with the new developments in radiosurgery would have to consider upgrading to the Gamma Knife Esprit. Frame and mask has really permitted versatility and the ability to hypofractionate our treatments. The other advantage, I know that a lot of devices in the market use onboard CT technology to localize the patient. The Gamma Knife cone beam is unique that it is mounted to the source array, and therefore when you acquire a cone beam CT, you are acquiring actual stereotactic coordinates, which makes the generation of a treatment plan extremely efficient. And as I said, always, it's been very finely focused beams from multiple directions, cross-fired. And even though they are photons, which is true for all radiosurgery platforms out there, cross-firing them through multiple directions really concentrates the dose on the target and really drops the dose very rapidly in normal tissue, allowing you to produce a neurosurgical precision lesion like a thalamotomy target shown here in the thalamus. The other thing that is very unique to the Gamma Knife platform from the operator, from the neurosurgeon's point of view, is that all the planning can be done directly on MRI, on PET scans, now on PSMA scans, something that is very unique because any platform that uses a linear accelerator to calculate the dose, you require a CT scan, and all the actual dose calculations will be done on the CT, which inherently makes you dependent on fusion technology to fuse the image to a CT scan to generate the treatment plan. And obviously soft tissue resolution, particularly of the level of nerves and detailed structures in the brain, is only possible with an MRI. And the good thing is that the Gamma Knife has always been able to do that, and so planning has advanced tremendously. Modern day planning platforms are not only automated in conjunction with segmentation, artificially intelligence-driven segmentation routines can very quickly identify normal structures, normal anatomy, and tumors and label them for you. So you can proceed straight to planning. Actually, from end to end using AI and advanced planning, you can generate a plan for about 30 brain mets in under 10 minutes. And you can do so again, should you make a change in your plan, very rapidly. Since it's an end-to-end verified system, no patient-based QA has to be done, which is another distinction from many other radiosurgery platforms allowing same-day treatment. As Sandeep will tell you, he saw a patient he was wanting to schedule for Monday, and the suggestion from the patient was, what's wrong with today? At which point he said, well, I may be late for Professor Banerjee, but I'm going to take care of the patient. And so he ended up treating, and then he texted me, all done and dusted. But this was not an easy journey. Just the concept of radiosurgery was quite alien to almost everybody involved in it. And we have had to change a lot of minds along the way. So the next sections of this talk will very briefly touch on how Gamma Knife radiosurgery transformed the way neurosurgeons think, radiobiologists think, and actually radiation oncologists think. We struggled with the idea that fractionation is the only way to treat tumors because when tumors cycle into a reproductive phase, they're more sensitive to radiation. Most of the neurosurgical targets were benign tumors or functional, where such cycling was not required, and giving a single dose actually carried the benefit of overcoming any resistance based on cell cycle. Hypoxia is another common radiobiological concept, very common in visible cancers like cervical cancer and head and neck cancer. Well, what happens is most of the hypoxic regions for brain tumors tend to be in the core of the tumor because they parasitize their blood supply. And what happens in a Gamma Knife plan inherently is the extremely hot spot produced at the core, which overcomes the hypoxic burden. Just to give you a sense, I placed the dose fall off from a Gamma Knife plan on an actual histology slide. And you can see you can drop 10% in your dose in less than 1 high power field. And that kind of precision, that tight penumbra, makes a big difference. We've also advanced a lot our understanding of various tumors and targets in terms of how they react to radiation and whether they would be better served with single large doses or served with a hypofractionated course. The good news is Esprit is completely capable of doing either. So based on pathology, we can either deliver the entire treatment in one day, which has been done for many, many targets over the years, craniopharyngiomas, metastatic tumors for certain primaries, and meningiomas, acoustic neuromas, because they share the same radiosensitivity as the brain, versus hypofractionating those tumors, which are much, much more rapidly dividing. And so you have all those options from one end of the spectrum to the other. What has now become apparent, and that's where radiosurgery continues to play a major role in the management of cancer, is that there is a difference in radiosensitivity of the primary and the secondary, something that people had never thought about because of the microenvironment. So this is large bowel or colon cancer, and if you look at it, the left band is radiosensitive, the right blob is radioresistant. And in the brain, which is the third graph from below, almost all the colon cancer mets are subpopulations that are highly radioresistant. So the idea that we shared that, we standard fractionate our colon cancer patient, we should standard fractionate the brain as well, was obviously flawed. And we didn't know all this, but we knew clinically that the response to a single session radiosurgery to some of these resistant mets, renal cell, sarcoma, colon, was much better with radiosurgery than with external beam radiotherapy. And that idea was definitely ahead of its time, and today we have data to prove it. The other thing that is a common misconception is that our tumors are best treated with similar doses every day. That is going to go very quickly out of the window because we know we don't successfully control everything we treat. And part of the reason is that there is a changing, migrating population of radioresistance that evolves within the cell. So this is all what we call in silico analysis, mathematical modeling, but there is definitely a growing body of evidence matched with laboratory work that tumors respond to your treatment and become progressively subclonally more resistant. So which means if we were to change how we fractionate or add an inherent built-in high-dose boost, we will overcome this resistance and kill those populations. Dr. Mehta very appropriately brought out the point that all technologies are not identical, and I definitely want to make that point just for a few minutes. We're all very smart people here. Let's not get trapped into the equivalence trap. This is PubMed's publications by keyword for Gamma Knife, CyberKnife, LINAC, TrueBeam, and ZAP. And I'll zoom in the area where all technologies are available, and on the right is an actual enumeration of number of new publications with each technology. 2024 is still in play, and we already have 937 papers using Gamma Knife as a thing. So what I find is that radiosurgery as an entity truly only exists because of the Gamma Knife. And as a result of its halo effect, a lot of other technologies try to mimic it. But there are subsequent issues that come with it, particularly when you look at linear accelerator-based techniques that are not using a standard LINAC. When you use a lightweight LINAC like in a CyberKnife or in a ZAP, you have to eliminate weight, and the most important weight component is shielding. In so doing, you essentially produce an undershielded LINAC, which means when pointed in a direction, say from top, the beam will actually provide higher body doses, and that's well documented, published, to the point that the National Health Service in the UK, in its specification for stereotactic radiosurgery, specifically warns against the use of non-gamma knife techniques for children. So just keep that in mind, and the ZAP is no exception. In fact, it suffers also from cross-imaging limitations because of table hardware, so you actually lose sight of the patient's position during parts of the arc of imaging. And that is a huge concern as well when you're treating over extended periods of time. But it's better seen from people who have everything. It's easy for me to say this. I don't have a ZAP. I've used a CyberKnife. I've used protons, and I use Gamma Knife. If you look at MD Anderson, they analyze their Gamma Knife, their hyperarc techniques, and protons, and they unequivocally found that if the same case was treated on all three technologies, they had much better conformality, which is essentially the precision of coverage, much lower spill or gradient, and very high selectivity when they use the Gamma Knife. So in effect, telling you that intracranial disease, skull base and up, really becomes an outstanding target for this technique. Gradient index, which is a measure of spill. So I already talked about spillage outside the brain into the body. Even within the brain, if you compare the gradient, the bright green dots are all Gamma Knife compared to other technologies. These were plans made by experts in their field. These were sent out to them. They were sent cases. They were asked to plan and send it back. In fact, some people even replanned it. The dotted arrow here shows you a resubmitted replan, which started to reduce the gradient, but still could not protect the cochlea. These are all acoustic neuromas. So if you start looking, this is all published literature, and that shows you that there are differences inherently built in, which is what Professor Mehta had pointed out, that when it gets to the brain, you really have to have this. And if you're a visual person, here's an example of a dynamic and a rapid arc plan for an acoustic neuroma. And here is a comparison example of a very commonly done Gamma Knife plan. Just to give you an idea, these plans take about 1 to 2 hours to generate and an overnight QA on a phantom before they can be delivered. This plan from drawing to finish takes about 20 minutes. And look at the gradient. You barely see any spillage outside of the target. In a place with a distorted brainstem, that can become very critical. And when you start looking at multiple targets, you will find that most platforms limit themselves to a handful of tumors. The old Brain Lab software would not allow you to plan more than 10. The new one allows more. But the moment you become intense in your planning on a LINAC or any other machine, summating doses becomes a huge issue. So you can either make one plan with a lot of off-axis spillage, radiation oncologists will understand what I'm saying, but if you are pointing at one tumor to calculate everything and treating anything more than 6 centimeters away, by definition, the plan on that tumor will not be as sharp because you're moving off-axis, shooting at an angle. And so you have to either make a plan for each tumor and sum it, which is arduous and will take a whole day. And here's an example. On the left is a 5-lesion plan, individually made and summated. On the right is a single arc plan for all 5 together. Now you can do this right-hand plan much more quickly, which is all the concept behind rapid arc is, but you will end up spilling more dose into the brain. And by comparison, when you compare it to a gamma knife plan, you can look at the low dose fields, 3 gray, 5 gray, and 10 gray, and you can see the dramatically lower volumes when you're looking at a gamma knife versus single and multi-isocenter LINAC plans. And here's a visual. There's the gamma knife versus the true beam. Now you'll say that's 5 tumors, that's not a big deal. But what about 44 tumors? And it's not something uncommon in our practice. And the comment I always get is, well, that's like whole brain radiotherapy. It's not. That light blue cloud is actually 3 gray, which is 1 fraction of a whole brain. So we've basically shown that if you are good with your timelines, you can get same-day treatment done, and that has value as well, because any non-gamma system requires QA and multi-day planning, during which time the tumor will grow. So if you decided to plan someone today and treat them a week later, if it's a melanoma, it could be 15-20% bigger. We already published this showing the interval growth. Lung and melanoma are particularly notorious for that. So we interleave our patients, we work efficiently, we can get multiple patients done in one day, but we do everything from end to end. And we try to get everybody treated very quickly. I think Sandeep's pretty soon going to hit into overload, but right now he is doing same day, maybe within 3 days. But we are able to guarantee treatment within 10 days for any patient that we treat. So all of these things kind of come together to try to explain to you why one technology may be more important. And very, very, very fast, I'll go through all the current indications. You got your vestibular schwannomas. Surgery used to be the mainstay. It still is for large tumors. I know Basant is in the audience. He will show me all the 60, 70, 80 cc tumors in the cerebellum. No question decompression is needed, but as correctly alluded earlier, you can combine it with radiosurgery without sacrificing the facial nerve. Control rates are very high, 94, 95% in everybody's data. You follow patients 5 years out. If they don't fail in that period, they're not going to fail. And the results look very similar. We also now know these tumors swell up and then they shrink down. When they swell up, that's not a failure and not a time to operate. But you will see if you follow them, the long-term controls are going to be excellent. We also have predictors of hearing outcome now for the smaller tumors. If you have intracanalicular CSF between the cochlea and the tumor, more than 0.04 cc, you're likely to preserve hearing better, and especially if you can keep the mean cochlear dose below 3.1 gray. And those early comparison vestibular schwannoma plans from the UK that I showed you that 3 gray line, and all the gamma knife plans were to the left of it with tight gradients, which is not easily achievable in every machine. You also have now good data to show that if the signal characteristics of the cochlea are abnormal, this is very important in patient counseling, you don't think that that hearing will be preservable, and so you don't promise that to the patient because the cochlea becomes duller and darker when it becomes less functioning. Within the pituitary adenoma universe, it's always a combination. Very, very rarely. There's a Korean series for doing direct radiosurgery, but nobody else actually ever do that. Most patients will get operated, and our modern techniques allow very high control rates, 80, 90%, very low failure rates, and mean time to response goes well down. So both non-functioning and functioning tumors respond very fast. Hypopituitarism does occur. It does occur in a percentage. I would say 30 to 40% in a very long follow-up, particularly when there was a big suprasellar extension and when the dose exceeded 16 gray for a non-functioning tumor. We obviously require higher doses for functioning tumors, and in those cases, therefore, decompression and clearing of the optic pathway becomes very necessary. In the pure gamma knife frame-based era, we required about 2 millimeters gap between the optic pathways and the tumor. Today, with hypofractionation, you can actually treat right up against the optic chiasm, and we did both types of cases last week. A pituitary that was far enough from the chiasm and we could treat in one day, and then another one that actually was draping, the chiasm was draping the tumor after big decompression and no room for more decompression, so we did a hypofractionated treatment there. The response rates for functioning tumors tend to run just a little bit lower, but they are still very good. In the meningioma universe, the only thing worth knowing about, we know we can control them very, very well with radiosurgery, particularly in tough locations, skull base, cavernous sinus, and non-grade 1 Simpson residuals despite the best effort. And they respond very beautifully, 95, 96% control rate. You have very good long-term control rates, 10 years, better than 87, 85%. So you have small numbers of failures, but you can still control them. The problem is that there has been a migration in pathology and there are much more atypical tumors now. So if you operate and you find atypicality, those patients are not going to do as well. And while we treat them, we definitely find there was a few grade migrations in here and certainly some high-risk ones. And as you can see, this table looks very different. This graph looks very different from a grade 1 meningioma. And since many radiosurgeries are done without pathology, sometimes we will have our outcomes diluted by the fact that there are some atypical meningiomas that we are treating without knowing what they are. The end result is still pretty good. The overall survival, anaplastics obviously are horrible. It's still good, but the reality is that it's a very different thing. In the universe of AVM now, we essentially, early on used to believe embolization was not our friend. We have very good data to show that you obliterate the AVMs, progressive sclerosis. Dr. Dixit is in the audience. I think he's probably done more AVM angiograms for gamma knife than anybody that I know. And he'll tell you that they obliterate very nicely. And over time, you see full closures. Now, what I can tell you is there is a dose response curve. We all know that. We try to push the dose as high as we can. And you have clearly some patients who present with changes, and about 6% present with effects from treatment, only 3% of whom will be more permanent. Our new data with onyx embolization tells a different story because you get better nidal penetration. And what we published is that you can actually have synergy between embolization and gamma knife. It only works when you get volume reduction. If you're not getting significant volume reduction well below the 5 cubic centimeter range, then you're not likely to fully obliterate the AVM. Trigeminal neuralgia is another pathology we treat a lot, and that is, this picture is up here because there's a picture I took of the Great Nebula in Orion 150,000 light years ago, and I can show you that nebula better than I can show you the trigeminal nerve sometimes. And that's been the big challenge here. But we put our lesions, there are lots of history to show you where the different lesions can be, and over time we have all settled on target number 2, the mid-cisternal target, and you get excellent results. The only thing important in this discussion here is the fact that we no longer prescribe a given dose anymore. We prescribe biologically equivalent dose, and that concept is right here. As your sources change, the dose rate changes, you have to give more dose to make up for the biological effect, and these type of simple tables are the way to do it. So today I prescribed 83 gray, a year later I'll be prescribing 85 gray to the same patient to get the results that I'm looking for. But you get very good responses. And I'm going to move quickly through because I think time is of essence, and I want to show you one more concept. Here is a tremor thalamotomy, and the reason this is very important for discussion is because you can perform a thalamotomy in lieu of a DBS for essential tremor. I think in India it might turn out to be a cost-effective solution because of battery and implant and changes and so forth, and you get responses like this. Here is an example of a patient with an essential tremor before thalamotomy, and here he is after the thalamotomy demonstrating with a pen that my tremor is gone. But if you do tractography, you can now see the effect. Here's the DRT before the treatment, here's the lesion, and here's the DRT when the tremor was gone. So essentially you can see that it has an excellent response. Again, we now prescribe based on BED, and we have now good data to show that flare matches very well with response to these treatments. I'm going to show you just a few things on glomus since we were doing one with a LINAC the other day. And this is our data for 66 patients. And you can see excellent control, but only for the cranial component. Getting deep into the neck, even with the Esprit, is not always possible. I'm going to stop here, keep to my time. We'll discuss METs along with the METs conversation. The only thing, one more thing I want to show you, and that is very important from a Esprit and to a oncologist point of view, is that there is great synergy when we do both together. So Nitesh is sitting in the audience and he will recognize that this waterfall curve shows you, if you start immunotherapy concurrently or immediately following within a week of treatment for brain mets with the radiosurgery, you get an amazing response because of the abscopal effect and an increased control. It doesn't work as well if you started before. So generally, we allow the radiosurgery to precede immunotherapy treatment. Alone immunotherapy provides about a 30% control rate with about a 30% volume reduction, even some of the newer agents. So if you combine the two, you're definitely going to see the combined benefit of both of those. Thank you. Do we have questions?
Thanks very much for this wonderful talk. I think we won't have the questions right now. We will have it during the panel discussion subsequently.
I think so.
Right?
Cover.
Everybody will have the opportunity to ask those questions. Thank you so much.
Thank you.
Thank you, Dr. Prasad. We'll now move on to our next scientific session, which is a panel discussion on brain metastases, a multidisciplinary approach, which will explore collaborative treatment strategy for brain metastases. The session will be chaired by Dr. B.K. Mishra, Dr. Pramod Kumar Jhulka, Dr. Hemant Bhartia, and Dr. V.K. Khosla. Moderating this session will be Dr. Dhirendra Prasad. And we also have an esteemed panel of experts joining us: Dr. V.P. Singh, Dr. Anushil Munshi, Dr. Vineet Talwar, Dr. Narendra Bhalla, Dr. Deepak Agarwal, and Dr. Ashish Pathak. And we also have Dr. Nitesh Rohatgi. So we've had a little bit of a reject, but Dr. Prasad, you're going to take over, please.
Yeah.
And may I make a small announcement, sir, before? Sure. So in the interest of time, we had set aside more time for the discussions, the panel discussion as well as the case discussions, but we're going to wind them down a little sooner. Dr.
I think 45 minutes.
Yes, we're going to do that. Thank you.
I think we'll be able to get through a lot of cases. We just want to make sure we are respectful for everybody's dinner time. And thank you, Dr. Banerjee, for staying. As I promised, I did not overdo my talk. Thank you. Thanks. All right. नहीं, ये लगा दिया। HDMI लगा दिया। इसकी ज़रूरत नहीं है। ऑडियो उसको ऑन करो। Just give me 1 second to get my laptop reconnected here. Okay. All right. It's not in the screen in front of you, but the first case we will talk about is a 30-year-old female diagnosed with triple positive breast cancer in 2017, underwent treatment from the primary with a mastectomy, chemoradiation, and then presented with seizures. MRI with contrast reveals this lesion in the left motor cortex, as well as another one slightly lower down in the centrum semiovale. So my question for the panel is, what would be the preferred treatment for this? Anybody feels free. Nitesh, maybe you should start because just press the button on that and get the... Yeah.
Is that working? Am I audible?
Yes, you
Okay.
are.
So I guess there are multiple ways to look at that. But essentially, this is low volume disease. You want to deal with it first, and then you want to start some systemic therapy. Of course, you want to know what's happening to the rest of the body. Is there a disease in the lung, in the liver, in the bones, or is it isolated to the brain? But my guess is, since you put the case, this is isolated to the brain.
So restaging with potentially radiosurgery and targeted therapy if any new agents are available.
And we have some very interesting new agents, which is why I said that's somewhat debatable. In the future, near future, we may be starting a systemic therapy first. But as things stand today, we'll deal with the local disease first.
Yeah, and actually breast is one of those that is notorious for presenting with brain mets years after the primary has already been controlled.
Yes. And to be fair, this is one disease which requires you to do both things at the same time. You have to put the patient as a whole. You have to keep dealing with small disease, oligometastatic disease, and you have to keep the systemic control ongoing, and they live for years together, so you cannot really lose your track on any one of them.
Yeah. Dr. Mishra and Dr. VP Singh and Dr. Yeah, I want to know what dose you would use for this treatment. What, you can't hear you? Oh, there is echo. Echo, okay. Okay, we can do that. If you want to sit in, पर वहाँ पे microphone. Okay.
I don't know about here, this side, I couldn't understand what
So I will repeat the question for you. I want to know from you and VP and Deepak what
did he
dose.
say?
Oh, what he was talking about was restaging followed by focal treatment, and if there is anything targetable available, use that together. So that was the plan. So now the question is, for you, radiosurgeons, what kind of dose you like to use, especially for that motor strip lesion?
Yeah, for VP, you want to go ahead?
Go ahead.
So there is, the lesion is right in the motor cortex. So I would try to reduce the dose a bit, but still at least 20 gray to the periphery.
He's 20. We keep it around 18. We don't give it more than that.
Yes, we always give 18 grays
Okay.
for metastasis.
So it's interesting. The reason I put this case up,
This is not for all metastasis, only for motor cortex.
I get it.
On metastasis, we try to give as high as 25. If it is a very non-eloquent area, for example, it is small, I would go ahead and give 25, 20, 25. But for motor cortex, we keep it down to 18 in our practice.
So a few things, the reason I put this up was primarily for this conversation. I think I agree 18 is a safe number for the motor cortex, but 18 is also a threshold number. If you give below 18, and it becomes relevant in the Esprit universe, if a size of a MET in the motor cortex is going to push you below 18, this is a small MET. I agree 18 gray is easily given and safely given, maybe even 20 under the right circumstances. But if you give it less than 18, then you are likely not to control, and that's when you move to hypofractionate. So that idea between single versus multiple session splits right at 18, and that's a paper published by Doug Conziolta and his team. I'm partial to it because my daughter wrote it, but it is definitely clearly a threshold at 18 when they start losing control. Now for 22 and 25, I just want to point out, let's not forget the concept of a chemorad and an immunorad. They're more potent. So most of us have dropped to 20, rarely 22. Those 24s and 25s have gone away. Conjolka always pushes for even lower doses, but most of us are still doing 18s and 20. You had a point?
So I think the golden rule is the smaller the lesion, the higher the dose that you can give, and we have enough data about that. And dividing the lesions into less than 1 centimeter, 1 to 2 centimeter, more than 2 centimeter, and dose ranging from 24 and going down as the lesion size goes up. Now the other factor obviously in this patient is the eloquent area issue. And so that is where we have to be on guard in giving the dose that we want to give, or whether we should fractionate a bit.
The other thing, when there is multiple meds, we drop the dose again. We are not going up right up there. So if you have many meds to be treated at the same sitting, then we drop the dose, about maybe 20, 22. Yeah. But single meds...
It's just not the number, it's the total volume of all the meds, rather
Agreed.
than just
100% agreed. The numbers don't matter as much as the summated volume. And there is very good data to show that when you cross about 7 or 8 cc, certainly when you cross 12 cc total volume, you will need to adjust your doses. Now, just to challenge you further, this patient ended up with 10 lesions. How would you treat this patient with access to a frame and frameless modality? They're all small, but there are 10 distributed all over the brain.
Will you not like to include the whole brain radiotherapy, this WBRT?
Great response. That is exactly the challenge I was looking for.
Yeah, but I think that was the thing before, but now the Japanese people have come out with the Australian guys are doing 35, so and in different sittings. So we don't have that option. We are still on the perfection. So we single stage. We don't hypofractionate.
Which is what we did.
Yeah.
We put a frame on and treated the patient.
Yeah.
But there is the other question that where take a patient with 20 or 30 brain mets and treat 5 or 6 each day over a course of 3 days or 4 days if they don't want to be in the machine for too long. But you still benefit from the tight field, the really low spread, and you're treating just the disease. NCCN guidelines, clinical discretion, but the number has gone above 10 now. And the reality is that if you ask our medical oncology colleagues, they will prefer not to have whole brain used for as late as possible. It's a salvage. It can be used for leptomeningeal disease, but generally speaking, and that is something I think AIMS is the only model where when you treat once, then you can come back and get as many more treated as you need. I don't think that's practically possible anyway. They go about 2.5 to 3 gamma knives in their lifetime. So it's not like everybody gets 8 or 10 treatments. They will get METs, but if they get competent treatment along with that, the METs velocity slows down. So the whole brain concept has really gone away. And the cognitive benefit of that is so huge that the patients, in fact, in young breast cancer patients who were younger than 40 years of age, there was actually a survival disadvantage to using whole brain, which is a really new concept.
But median intracranial control, as some of the papers mention, is better with the WBRT.
Yes, and the way to look at that data is to put it in front of the mirror and then you see the reality. The Patchell study said that about 34% of patients will fail in the brain, right? The radiosurgeon will tell you, if I can do radiosurgery as needed, you're making me treat 67 brains extra that will never fail. And that's really what's happened. The availability of radiosurgery in every hospital has changed the dialogue. So that's an important thing for the audience to keep in mind.
So this debate between multiple lesions, radiosurgery versus whole brain RT, that is one part of the debate. Broadly speaking, we have to take into account the number of the lesions and the volume of the lesions. And in the planning, the V12, try to keep it under control, the V12 grade.
Well, I agree.
Try to keep it under as much control as possible. So more or less, taking all these factors into consideration, and newer parameters are coming as well. For example, the brain met velocity and things like that, which tell us about the aggression of the disease pattern. So all these taken together guide us as to how we should proceed with the
I agree
patient.
100%. The brain velocity, Metz velocity.
I think I just want to add a caution for the wider audience here that, I mean, when we take that decision, we have to take the whole picture into account, because there will be those patients with multiple meds who have generally very poor tumor biology, not many therapy options, where you may actually still consider whole brain radiation.
I agree.
And that's what
I agree, and we would do the same. When the life expectancy of the patient is genuinely in the order of months, this argument holds because the median life expectancy of a Metz patient has gone out beyond years. Those patients benefit from delaying whole brain. There are those who are not going to benefit from any treatment, but at least whole brain will palliate their symptoms, reduce seizures, and give them relief.
And these days you have some very good online calculators that take into account the number of lesions, the volume of the lesions, the molecular subtype, the site, the primary site. Of a particular patient, I think we should make use of such tools for guiding our decisions better.
Yeah, so the idea of an oncotype and the concept of creating a predictive model is definitely needed, especially when you're looking at expensive treatments. Anybody else has a comment? Yes, please.
I have a similar patient like melanoma, metastatic melanoma. Patient have a 12 cycle of pembrolizumab and then have a 36 lesion in the span of 9 months. So it's not added one time. One time he has 3 lesions, sometimes 5 lesions like that in the span of 9 months, and treated with GNAP, gamma knife, and then after 2 years we did even the PET and MRI, and the brain MRI is normal, PET is normal, and even she run in the US a 200-mile cycle, and this patient we presented Astro 2017. So that was the 36 lesion.
And that's exactly the point of Metz velocity. What we all know now is if systemic treatments are going to take, the appearance of new brain mets without whole brain being used will start to decline. So you'll treat them a lot within the first year. Most beyond about 2 years will slow down and you'll get past that point. But when you get past that point, you would not have created damage in the brain. So the individual is still in there. These treatments are horrible for surviving cancer patients. That's what we're discovering. The longer they live, the more our treatments begin to show their effects. So the end result is you're banking on that. There will be those with bad biology who will declare themselves and keep failing, and that's when you switch your gears. But as far as possible, radiosurgery first, and I often joke with my residents that in a good democracy you vote early and you vote often. In good radiosurgery you treat early and you treat often. So this is exactly the point I was making. Many treatments later, this patient has gone, the behavior of lesions has changed, and we have controlled. Okay. Now, by the way, this patient had nearly 200 brain mets treated in the course of her lifetime, and she still remained intact, and that's the cumulative DVH of all those treatments. It's a 53-year-old male with esophagus cancer on systemic therapy, develops headache and imbalance while walking. Got good response, adjuvant primary RT has been done, there is no intention to resect, there is no measurable disease, and then you see this. Okay, so now the question is, a poll from the panel, who would consider radiosurgery, who would consider whole brain?
Hypofractionate. I don't want to get single stage for this.
So hypofractionated SRS.
Hypofractionated SRS, maybe like give the one dose 10 gray, and then after 1 month you can repeat the dose later on.
We have an amazing panel. They're reading my mind, so that's great. That's a good idea. Deepak?
I'm thankfully
I have to always ask Deepak because he's the provocateur in the slot.
Now, I would give 18 grays with shielding of the brainstem.
But you can't shield the brainstem. Tumor's in the brainstem. And it's pretty low. I gave you deliberately a tumor that's actually inferior brainstem.
Yes. So, but I think we can still go with single dose.
What single dose will you be comfortable with?
18 grays.
Anybody else will be comfortable with
Can I
18
ask a
gray?
question? I'm the only
Sure.
non-radiation oncologist here. Any data on what causes less edema? Because I'm very worried about edema in this area.
Okay, so what dose causes less edema or how?
What dose and what technology will cause least amount
Okay,
of edema?
we'll come to that in a minute. Let's keep going with the dose fractionation.
So there can be various aspects to your question. I mean, some people could argue that the amount of hotness that you create inside can be a factor for subsequent these things. Some people could argue the spill that you have beyond the lesion could be a factor. So there could be numerous factors for that. But for this patient, I would certainly like to fractionate a bit.
Okay. VP, what do you think?
If this is the only lesion, it's
Only
right
lesion.
on the posterior surface of the brainstem.
Right.
I would, do tractography and even consider a surgical resection because radiosurgery in this location, I think, would not be the right thing to do.
Okay.
But if surgically accessible, I may, and if this is the only lesion, yes, there is risk of deficit, but depends on how good the patient is. I would probably try to.
Interestingly, you are still less aggressive than Deepak, who wanted to give 18 and 1 to the inferior brainstem. I think an open surgical approach might almost be safer than a single large dose, particularly in the medulla, because you have so little, such a high density of tracts that we would take no chance with it. So I would generally say, if you're going to do something, you do hypofractionated radiosurgery, or you consider perhaps in an exophytic lesion resection, single lesion. Clearly, not doing anything or doing whole brain would probably not be indicated with just one lesion, although that could be considered if the prognosis was particularly grim. So just keep
You can do hypofractionated radiosurgery. You can do also SRT. I mean, it's
Right,
not,
absolutely.
I mean, that's quite appropriate.
Yes.
So that's
and
fine.
so once you hypofractionate, the penumbra effects go down a little bit. There is still going to be the tightest penumbra with a gamma knife, but you can play with different techniques. And the other concept that you raised, which is called adaptive radiosurgery, a whole other discussion, is very valid as well. Lily Angela from Cleveland Clinic published very good series showing you give 10 to 12 gray, you wait for 2 months, you give another 10 to 12 gray, and then you repeat that a third time, sometimes tailoring down the dose. Arjun Sehgal has done the same. The advantage is you're able to give a decent dose with a hot spot that gets up in a gamma knife. I know you talked about dose homogeneity. In fact, many of us believe the heterogeneity is our friend because it's inside the tumor. And that mean energy that goes up when you dose this to a 50% line actually benefits tumor control. And we only have indirect data for that. RTOG 9005, which is a terrible study, did include LINAC and gamma knife for, unfortunately, brain mets and primary brain tumors. So it was not a clean study. But what they found was the rate of failure in the LINAC-treated patients, which were homogeneous plans, no hot spot, with the attempt to reduce edema, actually had a 2.5 times less likelihood of controlling disease. The risk of failure was much higher, and nobody could explain it except by the heterogeneity factor. So the gamma knife hotspot isn't your enemy. But I agree that, you could go adaptive. The advantage of adaptive is that you shrink the tumor size. Next time you come back, you're treating a smaller target, and that reduces the risk of edema for you. Okay, well, we gave it a 12 gray single session and did exactly what you guys talked about, which is waited, allowed it to shrink. And the reason I gave 12 gray is that, at least on paper, the tolerance of the brainstem in a single session is 12 gray. So no one can find fault. I cannot imagine any way I can generate an 18 gray to the periphery plan for this tumor and not have doses exceeding 12 gray in a fairly small brainstem. So that's the biggest issue here. And if a tiny target exists, you can go up to 14 to 16 gray in the brainstem. But in a single session, giving more than that is rarely possible. And so you may have to come back and treat again, which in the case of the Esprit, you keep the mask with preserve it because patient might be back in a few weeks, 2 months, to get a touch-up treatment done. And if you stage it, maybe you can make it even better, stronger case. Okay. So we kind of addressed those questions incidentally. So we came up with the adaptive concept, which we just saw. And I'm going to present one more case, and then I think we should open this to the audience to ask us questions based on what they have heard so far. So here's a malignant melanoma, highly functioning individual, professional on immunotherapy, and he has a single left motor cortex met, and I gave it 18 gray, which is, I was listening to Basant, I heard him, and I said 18 gray it is. Well, 4 months later, this is what he presents with. Yes, that's a great question. What is the clinical performance of the patient? So the patient had showed initial improvement in their weakness, motor weakness, and is starting to present with some weakness again, and in fact had a seizure. So that's what has happened now.
So high-dose
Dr.
steroids.
Gupta is not in the panel, but it would have been very nice to hear from him about this. So
High-dose steroid first, because this is obviously radiation necrosis you have produced, and that's what you wanted to produce. You have produced a little more than what is desirable, and that's not unusual for single-dose treatment in motor cortex. And sometimes we get away with it with high-dose steroids. If you don't, then like VP said, you can go and decompress it.
okay, so certainly steroids, possibly surgery. It is eloquent cortex, BP. The risk of operating on this and making the deficit permanent remains. Anybody to your left who might give you a hand on this?
So,
With another agent, perhaps?
so I would consider for steroids, maybe tapering and then repeat an MRI after 1.5 to 2 months.
Nitish? 3 months later, the MRI is still looking angry, and patient is still slightly weak.
If he's steroid responsive and steroid dependent, bevacizumab would be a good option to be considered.
So that's our standard
Steroid
approach.
responsive and steroid dependent.
Yeah, so certainly we consider surgery. We would consider it particularly if there was a bigger solid component. When it's just a rim of enhancement, sometimes the resection is potentially going to make the deficits more permanent. So temporize with steroids. If they're helping, great. If you're entering into steroid dependence, we end up with using 3 doses of Avastin, which tends to produce a very nice combined response. But you know, it's a matter of opinion.
Right. So if your steroids don't work for 6 weeks or 8 weeks, and the patient is getting worse, then surgery is more easily justifiable. He may have already developed a bit of a deficit where you won't possibly make him worse, and you know, steroids certainly to temporize.
No,
So-
surgery is definitely possible. I mean,
I agree.
It is
we have operated, and you do awake with all this monitoring and all that, and you're not going to take it out. You want to decompress it. Basically, you are not going to trying to excise the lesion. So, in fact, some of these patients do better actually.
I deliberately picked
If
a
you're
really on-the-edge case, not much gyral expansion, little bit of edema, and what I'm showing you on the screen now is what's called the contrast washout or clearance analysis, which will, it's a terrible scan, but anything tumor will be blue, everything else that is red is just treatment effect. So essentially, if I was to tell you that this analysis tells me there is very little viable tumor there, we're really dealing with just a ring of necrosis, would you still push for the surgery? Agreed. Well, we didn't listen to you. We didn't operate. Here's what we have now. A few months have passed. The weakness has slowly been worsening, and now we have a different appearance on the MRI. It's just poorly positioned. I wish I'd fused them together. It's the same tumor. It's the same gyrus. It's just cut the wrong way. Same patient. Same patient. Now we're seeing that ring has become solid.
How long after?
This is now 14 months later.
Oh, you can go back again to steroid surgery again.
Okay, so this time I'm showing you contrast clearance analysis again. Now it's all blue. It's tagging places that fill with contrast and empty as tumor. Those that accumulate contrast but don't empty quickly are damaged brain. So now we have a recurrence in the same site as the radiosurgery, obviously because we limited our dose to 18 gray in a melanoma. So we ran into that trouble. So now VP is smiling because he's like,
why
oh,
not debulk and then radiate?
Sorry, I can't hear.
Why not debulk and then radiate?
So absolutely agree with you.
Yeah.
Now we are looking at actually a disease that's even bigger than when it started before. So even if we chickened out of doing neurosurgical intervention back then, when I was selling you the idea that there is no active tumor, I was obviously wrong. And we know when you take it out, it's always a mixture of necrosis and a viable tumor. So it's now failed, and the patient is again having seizures. And I think seizures are a big indicator for intervention as well. When a patient is actively seizing, it means you're irritating cortex well beyond where your tumor is, and surgical decompression is really effective in controlling and improving, because sometimes their weakness is just because of repeated seizures and almost mini ictus.
My only comment, DP, would be that I won't just want to decompress like you said. I mean, if you're going to operate, I would like to excise. I mean, keep your margins tight, but you know,
But it will be excise, but there will be always malignant cells around it.
Right,
So
right.
you're not going to have, in a motor cortex, I would be more conservative. Other places, yes. There is data, of course, there is data, what you're saying, the Texas data, that when they have excised en masse, you know, this, what is it?
Ray Savaya.
Yeah. So
Savaya's
they,
data.
they excise and they had better outcome.
Yes, the
But
concern...
not in a motor cortex. I wouldn't be doing that in a motor
Yeah,
cortex.
so that's
But
what
you
Ray
see-
found too. Unblocked resection brings up a different idea. When you do neurosurgery for a tumor like this, and you spill the tumor, you produce leptomeningeal risk. That goes up to 14% with piecemeal resection. Unfortunately, in this location, it will always be a piecemeal resection. And as it so happens in American neurosurgery, we don't operate and remove these. We retreated it with 3-fraction radiosurgery, expecting a different result by doing the same thing over again, and gave Avastin. So the point we made is that we retreated, but we did it under Avastin cover this time, electively administering Avastin, so that we could prevent a second round of reaction and irritation. And actually, interestingly, this patient did very well. We have about 17 minutes on this session. Instead of showing more cases, interestingly, in just about 3 or 4 cases, we covered a lot of discussion about metastatic disease. So what I want now is to encourage the audience to ask any of us questions that have come up in their mind or thoughts they have, or if they disagreed with any of the things that all the experts have said.
I had a
Including those
question
on
for
the-
you.
on the- Go
I
ahead.
have a question for you. I think it was case number 2 or 3 where we had a brainstem lesion and you decided to give 12 gray in a single fraction. So there is a school of thought that if you're giving single fraction, don't go below 16 to 18 gray if you have to be effective. So what is your thought and your take on how low can you go with a single fraction dose, and what is the thought process and what is the scientific rationale?
Okay, so you're talking about staged radiosurgery.
Yes,
You're going to give one.
staged versus fractionated at upfront.
So I'll answer this both ways. If a single session is being done in that location, 12 was my theoretical limit. This is also technically with us already having the icon, not the esprit. So we could have hypofractionated, but because it was low brainstem, this patient's body habitus was such that I would not get a really reliable fix with a mask. I was very concerned, so I framed and treated single session. So that boxed me in. Now, if I could hypofractionate, so the dose tolerance of the brainstem runs in the following manner: 12 gray in a single session, 18 gray in 3 fractions, and 23.5 to 24 in 5 fractions. So that's where you start doing the math of biological equivalence, the alpha-beta ratio of a melanoma, and you start debating how high must my dose be for control. So if I'm going to give all the dose in a short span, I would probably have used 5 fractions, and I would try to push the dose to 25 and 5, while respecting brainstem at 23.5, which means I would not have a plan with 100% coverage. My plan GTV would actually be covered to the tune of 95%, leaving a cold rim from 25 gray to 23.5 gray to the edge of the brainstem. That is one approach. If you do staged, then you give 12, 12, and 10, or you give 2 and wait and see if the response is great. Don't give any more till failure occurs. So that's the other approach.
So you had a very interesting presentation, and that covered the length and breadth of everything metastatic disease that we see, at least in my field. Where would you still use not gamma knife?
Still use?
You would not use gamma knife in
And
metastatic disease.
You mean use a standard fractionation approach?
Anything but gamma knife.
Well, so you're talking to the crazy guy, all right? Only balanced by Deepak at the other end of the platform. I think we may be the most aggressively, solidly gamma knife guys out here. I have even gone to the extent, if I have to use whole brain, I do hippocampal avoidance planning, and any mets that are remaining in the hippocampal avoidance area, I boost them with the gamma knife. So I'm still getting full control. Now I'm doing whole brain, but still not doing, because typically if there's a met in the temporal lobe, they tell you hippocampal avoidance should not be used. So we actually, and Vinay Gandhi, who was the lead on that trial with Minesh Mehta, actually tells me he does unilateral hippocampal avoidance as well. So think about all those flavors. You're moving to whole brain, you're still sparing the hippocampi or the hippocampus, or you treat with hippocampal sparing and electively plan a boost to those tumors. That's only about 5 gray more, because RTOG allows you 14 gray to the hippocampus.
Yep.
So you're able to give another 5 to 7 more, and you're back up in the 19-20 range, single session. It's not quite that much because there's a little bit of loss in the hypofractionation B device, but it's pretty close.
And is the learning curve steep, or is it a very fast learning curve? Because I mean, it's a new machine, isn't it?
For using this combination of tools, very easy. Very easy, because see, all that will happen is that you decide you're going to do HAI-MRT, then Amal or somebody is going to generate the HAI-MRT plan, ship that plan directly to the gamma plan computer. You can actually measure how much dose is going to each of the tumors that you're in that field, and you boost them accordingly. So it can be done pretty much real time.
So I have a question regarding just multiple brain mets, patient on chemotherapy and asymptomatic. We did the MRI. We know there's a multiple small mets in size. So asymptomatic, you still want to do gamma knife, or waiting to medical oncologist to give after the chemotherapy is over?
Absolutely.
Asymptomatic patient.
Asymptomatic is fine. Most mets, small mets are asymptomatic. We have 2 pieces of data to support that. One, a certain number will fail anyway. If any is eloquent, if it's a really tiny met in the brainstem, tiny one in the motor cortex, treat it now when it's still tiny. You can treat it. But when you're there, you might as well treat everything else. And if you're giving immunotherapy in particular, controlling brain mets with radiosurgery potentiates systemic control as well. It has an abscopal effect that actually extends outside the brain.
So I think the answer to that depends on what you're dealing with. If you're dealing with an ALK-positive lung cancer, the answer is you start with the systemic therapy first. But if you're dealing with, I'm just saying that's a tumor board decision, you know. So these are very specific situations. I don't think we can generalize that.
Dr. Prasad, one question for you.
Yes.
We have read, and it's proven also, that gamma knife has an overall accuracy of, let's say, less than 1 millimeter, including imaging problems, including positioning and everything. So overall accuracy itself, the actual accuracy of gamma knife is quoted as 0.1, but when you see the overall accuracy, it comes to less than 1 millimeter. For cyber knife, the overall accuracy has been touted as 2 to 3 millimeters, and for proton beam, it can exceed 5 to 7 millimeters. So in that scenario, still do we recommend proton beam and cyber knife for small lesions anywhere in the brain?
How to answer this in the most unbiased and technical manner. First and foremost, the stated accuracy end-to-end for the gamma knife has to be better than 0.3 mm to be delivered to you. You can't get a gamma knife if it's not better than that. I think the Esprit is measuring it out at 0.1. So that's dramatically lower. Mine measures out at 0.14. Each machine will be slightly different. That's end-to-end. It's reproduced best with good imaging, properly calibrated MRI, and a frame, particularly if you use Vantage, which is non-metallic. So then you get your end-to-end creeps up, but it still stays well below 0.5 mm, okay? When you take the frame away and put the mask on, then you can actually track the patient's nose and you see what the error in your positioning is. And just keep in mind the nose is a surrogate, brain lesions move roughly 1/2 of where the nose goes. And if you set your nose threshold to 1.5, you're allowing 0.7 millimeters movement. So that's literally the most lax scenario with a gamma knife. Couple that with the tight penumbra of a 1 MeV beam and the really beautiful geometry of almost 200 finite size pencil beams that are converging in one point. Can you come up with that exact same plan with another platform? Protons later. With photons, you can. It will be ideal done with a frame. If not possible, then your mask. So you have to calibrate your table. Age of your machine matters. CyberKnife is not one thing. Every generation has different performance things. And as it ages, it changes. The penumbra is always going to be wider because it's a higher energy beam. So the suspicion is that you're right. It probably ends up above a millimeter. And then if the total penumbra and target size limitation is more than 50% of your tumor size, you're already out of range. Now you're clearly going to treat surrounding tissue, and that is why a lot of times hypofractionation becomes used so that you can mitigate those side effects. Particles are a whole other story. Particle is highly planning dependent and platform dependent. So if you're doing scanning protons, even then really small targets are difficult. If you're using scatter, it's completely not comparable. Nobody does proton radiosurgery for Mets, even in the United States, on a routine basis ever. So there is a reason for that. I think it's not going to work out, and it's going to be an extremely expensive way to do something you can do much better with other platforms. So, you know, sticking to facts, so to say.
So, I would like to add on this.
I want them to ask you questions. You're asking me questions. Okay, go ahead.
No, we just installed the new Electroverse SD in Mohali. So they add on the cone of size of 5 millimeter to 15 millimeters, so using for particularly SRS these mat. So the accuracy with DMAT plan in the photon also is getting much better with this cone, 5 millimeter, 15 millimeters.
I agree. Cones are always the way to go. MLCs are not enough. And yes, a well-calibrated cone-based system will give you a good result, but still the penumbra will be bigger than with a gamma.
There is no doubt. I think the biggest USP of gamma knife is the sharpness of the fall-off. There is no comparison.
Agreed.
The sharpness is so dramatic as you go beyond the target lesion. I mean, within millimeters, you see what dramatic sharpness
Actually,
fall-off is there.
I couldn't get into it in the talk, but the sharpness and the end-to-end rapid workflow actually made radiosurgery what it is today. Because it's real time, you can get it done, and it has changed radiation oncology. Because now all body SBRT essentially follows in the steps of brain SRS, which was almost all, as you saw, historically all radiosurgery with the gamma knife. Yes, finally we have an audience question, maybe more than one. Yes.
She's taking it.
Yes, please. They're getting your mic.
Asha Bakshi here. Nice talk. This question is for the panelists. What's the maximum number of mets in the brain that you would treat in gamma knife? And in the 17 years of gamma knife therapy for metastasis, what is the survival rate that you've seen? Thank you.
I can answer the maximum number question easily. The median number we treat now is 7 to 8. The maximum I've treated at one sitting was 65. It's a 35-year-old young school teacher with breast cancer. And we just treated all of them with one frame application and a long treatment. So that's numbers. Survival is actually squarely in Nitish's hands. We don't keep these patients alive any better or longer. They do. All we're doing is making sure when they keep them alive longer, we've not completely damaged the brain. That's the main thing.
But how?
So I'll thank you for that, but I think it's vice versa. If the brain is not controlled, nothing ever works.
So what did you say? I'm sorry, I missed it.
I said if the brain is not controlled, actually nothing works. No system. There is no point in controlling a patient's systemic disease if they're actually dysfunctioned by brain. So it's a very critical part, and that's why these patients have to go through the TMO board again and again.
Does that answer your question? What is missing from the answer?
Nobody has an answer for it, probably.
Well, I can tell you, we have any number of patients in whom over their lifespan, we have treated them for hundreds of mets over 5-6 years, usually breast, a lot of melanoma patients, because these are young women, triple negative, they really are struggling, and if they lose their ability to think, then it becomes a real problem. So they have stayed well, and over time the Mets velocity slows down, and then they stop getting new brain Mets. So we have that. We have one more question.
But the survival, I just want to make the survival is not dependent on the Met treatment. The survival is dependent on the primary disease. So it's different for every different type of cancer. So that's not a one question. Breast CA is different than a lung CA, depending on what sort of type of type of tumor they have.
I mean, EGFR mutant lung cancer today, the treatment is so revolutionized that you control the Mets that are significant or eloquent, that some of the rest will disappear with the targeted agent, or you don't do any radiosurgery and watch for a bit. Generally, I still think you end up treating them, but they live long and they live clean. I have actually the father of my colleague and 3 other people I know personally who've had this happen, and when they are on the anti-EGFR agent, Tagresso, they're doing great. But if we had given in and treated their brain because of multiplicity of brain mets with anything other than SRS, they would not be thinking clearly that they are. Yes?
It is very difficult for me to digest that 65 lesions have been treated. I mean, it would amount to irradiating the entire brain. And are we justified in leaving areas of 3 gray in such a brain? It is rather better to treat the entire brain and keep treating them again and again and subjecting the patient to gamma knife treatments.
That's always been the classic, and I know it's hard to digest, but we have been able to get past that, at least in most modern day practices. The number of lesions doesn't matter, and what I showed you was the 3-gray crowd did not cover the whole brain even. That's the whole treatment. So it's like one fraction of whole brain, and you control other mets as they come along. Generally, if you treat this many, it's not like they will have another 55 weeks later. They generally have 1 or 2 new ones that pop up, and we treat them as they come. The number doesn't matter, it's the total volume. These are all tiny mets. If they are really large mets, even 10 of them, they often end up getting whole brain because the volume of disease is so high. I'm talking about microscopic, tiny brain mets, often asymptomatic. Yes?
One last, sir.
Sure.
We are very few in numbers. Me, Nitesh, Professor Raina, probably 3-4. We are minority medical oncologists here. But ALK positive, multiple brain disappeared. And one comes in hyperparietal. Dr. Sandeep Vesh will operate or he will give a gamma knife.
Right.
And ground data is published. 5-year DFS, patients are living. 2 parietal comes. No asymptomatic routine surveillance on PET. You would operate or you would go to a gamma knife way. I'm a medical oncologist, I just want to know this.
Well, generally, I regard gamma knife and surgery as an interchangeable decision based on your patient situation. And these are the people who will benefit from minimally invasive procedures. So if it's not eloquent or posing a threat, they will go ahead and do radiosurgery. But if it's appeared in an area where the concern is it's failing your ALK-phos agent and growing, and it could cause neurological deficit, that might change the answer.
So Dhirendra, if I operate and I'll continue Lorla, I'm still achieving cure. The intention is still cure. So with gamma, the same intention can be achieved or not, that is.
Yes, we can. Amal has a question. We'll do one more question before we switch gears to
the point which you did not actually post-metastasis excision and gamma knife radiosurgery.
We didn't talk about cavity at all.
So,
cavity radiosurgery.
That's
I mean, absolutely true that the classic teaching was you operate in the cavity, then you give whole brain. That's now out of the window. The classic understanding is you treat the cavity with SRS. Amal, your question, last question.
It's not a question, I'm just elaborating and going ahead with what Ankur has said. So you must be aware that Syndas trial results are, the early trials have shown that Syndas I'm talking about, where they have addressed the same issue with osimertinib combined with whether to give radiation upfront with SRS versus continue osimertinib. They have found increased OS and PFS when they have given SRS along with osimertinib. Secondly, there is another trial, I've forgotten the name, it's still accrued and going to address in ALK positive. Somewhere down the line, yeah, whatever said and done, these drugs are changing our thought process, and we need to involve all the team players when taking such a crucial decisions. But the fact that if you don't have a local control, robust local control, these drugs are eventually going to fail. So that's what we have to.
And kind of that's the point we kind of made.
Amal, that's exactly the point. Each patient is different.
With microscopic disease.
Yeah,
that's what.
Each patient is different. The data on lorlatinib, 87% control at 5 years was a standing ovation, but that's still 13% patient who did not respond. So I'm saying each patient is different. You need to pick that up.
See, there is a data from that itself that any tumor which is 3 centimeters and above, it is better to treat upfront, either through whatever surgery or SRS. So all the subsets, all the little finer points needs to be considered there.
Okay, I think we'll close the session. I think we covered a lot of ground here. I'm sure there's more we could talk about all night, but I think that it's a good idea that we got a lot of these questions answered. Thank you, everybody, for your participation.
Thank you to all the panelists and the chairpersons, as well as the moderator, who's maintained time. So this evening is the time for launches. We're going to take 10 minutes to do another launch, and this one's a really important one. So we're releasing a textbook called Spine Tumors, Comprehensive Insights and Innovations, which offers essential and advanced topics on spine tumors in an easy-to-understand manner. This book has been written by Dr. Sandeep Vesh, Dr. Salman Sharif, Dr. Zia Goksalan, and Dr. New, if I'm hoping that the pronunciation was correct. This book is a comprehensive textbook, and it will be extremely useful for neurosurgeons, spine surgeons, and other consultants, as well as practitioners working in the field of spine tumors. Please join me in congratulating the entire team, and to lead that, may I please invite on stage Dr. Sandeep Vesh. So I'd like you to speak a little bit about this book, and then of course we'll invite Dr. Mishra and Professor Mehta to unveil this.
Yeah, so actually the book is in publication, so it will be published maybe a few weeks from now. So this is just a cover which was made for today's event. We were trying to get the book by today, but it was delayed. So this is a collaboration between World Spinal Column Society and World Federation of Neurosurgery. And I'm really honored that two of the best neurosurgeons in the country today are here to unveil the book, and that's why I took this opportunity to do it here. Please come, sir.
Thank you so much. We now move on to our final session for the evening. And this is a pivotal case discussion, and it's called Choices, Combinations and Challenges in the Quest for Optimal Care in Neurosurgery, Meningioma, Acoustic Neuroma, AVM Trigeminal Neuralgia, and Pituitary Tumors. This session will be chaired by Dr. Vinod Raina, Dr. Munish Gairola, Dr. Rajkumar Deshpande, and Dr. S.S. Kale. Once again, moderating this session will be Dr. Dhirendra Prasad, and our panel of experts, Dr. B.K. Mishra, Dr. Dwarkanath Srinivas, Dr. Manjul Tripathi, Dr. Aditya Gupta, Dr. Manmohan Singh, and of course, Dr. Sandeep Vesh. So one request to all the panelists sitting here, I think when you speak, I would request if you speak directly into the mic. I think what happens is then it's much easier for the audience to listen to what you're saying. So just a little care, please, when you are addressing. I think that should be it. Thank you.
For a little variety, this time I won't present the cases. I will have Dr. Dwarkanath Srinivas do the presentations. Let me just open. Okay. दूसरे पे ना स्क्रीन पे हाँ करो 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 हो गया ठीक है
Thank you, and so thank you, sir, and congratulations for the new Esprit. So I'll just go through a few cases, and I mean some of them are straightforward, some of them are a little complicated. So this patient, unbled SM grade 2. So if many of the panelists remember, there was the Aruba trial which was conducted, which the results came out a few years ago, where it was said that in unbled AVMs grade 1 and grade 2, conservative management is better and has lesser complication than any form of intervention. So this is an unbled SM grade 2 AVM. So what would be the opinion of the house on this? Eloquent cortex.
They can't see, the panel can't see, so they'll have to turn around for this one. Let's start with Dr. Gupta. Aditya, start.
So my question is, what did you say? What's the age?
Age, she is around 28 years old.
28-year-old lady presenting with a seizure.
Yes, seizures and a vague headache, otherwise asymptomatic, unbled. So the whole question was a debate on the Aruba study versus when conservative was compared with any form of intervention, and they said conservative has better outcomes.
So, see, the Aruba trial, of course, has been criticized widely, and there are a ton of papers which have criticized the conclusions of the Aruba trial. So much so that people have said if you accept the Aruba trial results blindly, would have to negate the literature which existed thus far.
Can I ask for quiet from the audience? Conversations are great, take them outside. Please. Go ahead, Abhay.
So what I'm saying is, you see the Aruba trial, going by the Aruba trial, this lady should have absolutely no treatment. But that's not exactly true. Because you see, we know that a young lady, 28 years old, she has a definite lifetime risk of bleeding. And the location is not entirely non-eloquent. So if she does bleed, she is definitely going to land up with a problem. So I think this is one of the stark examples in which we have to say Aruba trial is not the evidence to be applied in this particular case. So personally, I would say unbled AVM, one single seizure. In the angiography, you don't see any reasons to intervene endovascularly. This is not a great location for surgery. Radiosurgery is a great option.
Yeah, how about, I got the mic here. So, Manjul, what is your thought?
So I am in complete sync with the opinion of Dr. Gupta. Looking at the location, at the age, I would also like to have a look on the SWI if there is any evidence of a microbleed. That would definitely further strengthen my proposal for the radiosurgery investigation.
Okay. Would the presence of an intranidal aneurysm change your decisions?
If it is an unbled one, definitely not. I would directly just treat the AVM. Probably with the AVM obliteration, that aneurysm would go on its own.
Dr. Kale, pre-radiosurgery embolization, any role?
Yeah, so, hello. Yeah. So it does definitely have a role, but is that always for the good? That is the question. I mean, the whole debate is about whether post-embolization gamma knife versus only gamma knife. Is that, which is better? So we would here not go for any embolization. We would go straight for gamma knife.
Okay.
So I think it's a point well taken. The Aruba study had huge flaws in the way it was constructed. So we did gamma knife in December 22. We gave 23 grays to the 50% isodose line. And this was the scan at the end of 6 months. We were quite happy, but there's a little bit of edema over there. And then this patient came at 1 year with this picture. You see the hemiparesis had worsened. And significant edema had occurred. So now what would you do?
What dose did you give?
23 grays to the 50% isodose.
23 gray. What was the volume of the AVM?
Volume was around 3.8 cc.
3 point?
3.8.
Okay. Sandeep?
Just treat with, right now I would just treat with steroids and see the response. And we have seen few patients with post-radiosurgery significant edema, and those who didn't respond to steroid we give bevacizumab, and they responded pretty well to that.
Dr. Rana, what is your thought process of using bevacizumab in a vascular pathology?
In a vascular pathology?
Yeah, this is an AVM, so
I'm sorry.
Sandeep is asking for Bev.
Medical oncologists have no opinion because we don't do this practice, and I'm not aware of any data of bevacizumab in such tumors.
So there has been a lot of interest in anti-angiogenic agents in the management of AVM. Yeah, so necrosis, yes, but see, it's ultimately a VEGF inhibitor. So from beyond the oncology perspective, VEGF has a lot of value in treating endothelial lesions like this. And people have started thinking about them for complex AVMs that are too large for treatment. And so there is a room to explore this idea for these type of AVMs. And of course, once it has achieved this kind of edema, sometimes the concern is bleeding risk. Dr. Manmohan, what is your thought in this case?
Start with that steroid is definitely interactive to begin with, and bevacizumab is definitely going to help these patients. And few of the patients, they never respond to any therapy. So So that is also a group of patients, and then the surgery is done. So they just take that whole necrotic mass out, and they really respond well.
Basant, what do you think about the dynamics of this AVM? Why did Dwarka's case end up with so much edema?
I don't know. It's a small volume AVM, so I don't know why there is so much of edema. I agree. We have no experience with bevacizumab. We give steroids, and if it fails, then excision.
So I think for the medical oncologists in the room, you will be asked to give bevacizumab for this. Dr. Mehta, you have a comment?
This stage, I would like to know the angiographic finding at this stage.
So angiogram was not done. This patient.
So my argument is, because I have seen such cases where the veins are blocked, but there is some arterial supply still continuing, and therefore there is such a severe edema.
And so if you go back to the good old microsurgery days, you always tested with a temporary clip every vessel because you can't tell the arteries and veins apart, and you always held back from touching the veins. This is the classic situation where radiosurgery takes the vein earlier than it takes the entire arterial supply, and you end up with this fulminant edema. In embolization, it happens too if you get the glue in the wrong place.
I'll tell you what, we have had a few cases where the AVM is completely gone, angiographically approved, repeat angiography like Dr. Mehta asked, we have done that. Patient had hemorrhage also, but no AVM. And there is published literature also, very few cases, where supposed to be, these micro vessels or, which are not seen, angiographically occurred vessels, which bleed. We have, I think, a couple of cases, and one of them we had to operate. One of them with continued steroid. They need steroid for a very long time. That's the problem.
So there is actually very good data showing upregulation of VEGF in a treated AVM field. And that upregulation continues long after the hemodynamic closure of the AVM. And that is where these angiomatous change and small microvessels, which don't lead anywhere, they're not longitudinally conducting blood, but locally they're friable and they can bleed, and you can get cavitation, even cavernoma formation in patients like this. So that's kind of where this comes from.
Cavernoma, is very well known for a very, very long time.
Right.
Post-radiation, not radiosurgery, any radiation.
Exactly, yes.
So I think this VEGF upregulation is much more common with the embolized AVMs rather than primarily just dealing with the radiation.
And embolization is a very potent VEGF upregulator because it's a dynamic flow change, it occurs very quickly.
So this again, this is a scary image to see. You take a completely normal patient.
I just want to make a point. These scary images, sometimes the patient is absolutely all right.
No,
so
this patient,
a lot of dichotomy.
the patient came to emergency with hemiplegia.
I know, but I'm saying there are a number of patients where the image is scary, like you did. Patient is walking around without nothing at all.
I agree. So this patient actually presented to casualty with hemiplegia. So we were seriously contemplating whether to do a decompressive craniectomy or just start steroids and observe. So we gave high dose steroids, and luckily over the next 48 hours the patient started improving. So and we decided to continue the steroids for a longer time. We gave almost for around 10 to 12 weeks with the hope that if the patient improves clinically, we would not have to give bevacizumab or do a decompressive craniectomy, and luckily the patient improved over the next 2-3 months. And actually there's another interesting point. If you see the contrast images, there's only a peripheral enhancement. There is no central enhancement. So we, like what Professor DSM sir said, we had thought by this time the AVM must have got obliterated. And so once the edema settled, this patient came just, I think, last OPD. And if you can see that the AVM has completely disappeared at 1.5 years. This is an unusual case in the sense that the obliteration has occurred up very early and managed satisfactorily with just, the edema was managed satisfactorily.
Probably this edema or this kind of an appearance is an MR signature for a better predictive outcome of these AVMs. In a short time they may show this kind of an appearance, but they obliterate earlier than the routine AVMs.
That is absolutely true. When you see that early, you feel happy. It's when you see it get like that, that's when you worry.
So,
Dwarka, I have one question.
Is it related to the dose? You think if the dose was lesser, would have got a lesser? I think it's what Sir pointed out, that probably the venous obliteration has occurred earlier than the arterial obliteration.
I have a question.
Sir.
For my co-panelists as well as for Dhirendra Prasad, is there anything done on the draining vein shielding in AVMs?
Okay, yeah, that's a great question. So if I see a single large draining vein, now you can combine catheter angio with rapid CT angiography and even Dyna-CT in the same platform. I use BrainLab software for that. And you can really do a phase-based segmentation and identify major draining veins. And I have often planned by creating that as a risk zone and underdosing it deliberately. The problem is that sometimes the arterialized nature of that vein makes it so that as the flow starts to drop, it disproportionately slows down in that vein and you still get thrombosis. You can't predict it. For tiny AVMs, it was very common. Pierre Lajunias used to actually go transvenous and embolize these when he was not worried about the swelling and so forth, because if you took the vein, you took the AVM. We are obviously trying to avoid that and in large AVMs. In angiography, if you're doing embolizations, my colleagues will tell you, if they start to see venous stasis, it is an alarming sign. Yeah. If they see the dye not flowing and they've finished embolizing, they give a squirt and it patullously sits in the vein, they prepare for craniotomy because that brain will swell. Radiosurgery is the same. We just don't have the angio to show it. You can do Dyna-CTs in between though, if you're concerned. And that will give you a pretty good idea of venous caliber. But yes, we shield it.
So the next case, this lady presented to us in 2011 with this imaging. A large grade 4 Spezza-Martin AVM, just occasional headaches. So what would be your line of management now? No, I don't have the angiography for this, but
Nil active,
Sir?
tender loving care, nil active as far as I am concerned.
Anybody else? Would you like to intervene? Would anybody like to intervene at this stage where the patient is just presented with occasional headache?
I would like to keep her under watchful observation because I see a predominant deep venous drainage, and that's a very bad sign, prognostic sign in this lady actually. So if the headache is just occasional, it's not a bothersome one, I can just observe for some time, but I would definitely keep her under my watch.
So, I mean, that's what we did, and I think almost 4 or 5 years later, she did present with a bleed. And this is the same AVM. It's almost the same size, but this time she has presented with bleed. So what would you do now?
Anyone bold enough to take that?
Yeah,
This was 11 years after the...
Yeah, so that's
So
okay.
this
That's
is
okay.
a
I mean, that's
pretty
known. That's
large
very well known.
AVM.
Pardon, sir?
That's known. I mean, that is known. But the standard of care as of current evidence we have, the state of knowledge we have, what you did is right. I mean, I don't think it is appropriate for going in the first stage. Now that he has bled, now you have that, that insurance to go in. So I would do staged embolization followed by staged radiosurgery. Unless the patient is too bad. How is the patient? If the patient has a big hematoma, I need to go in. Otherwise, staged embolization, staged
No,
radiosurgery.
the patient is well preserved,
Yeah.
but she presented with bleed and...
Yeah,
which resolved.
staged embolization, staged radiosurgery.
Yeah. So actually, if you ask my guys, Siddiqui and Levy, they would do a combined transvenous transarterial approach, obtain access, protect drainage, and then do staged onyx embolization over. Usually we did it when we did the number ranges from 1, in this case probably not 1 to 11, a median number of about 3 embolization procedures. Get good understanding of the anatomy, leave that remnant which is close to the vein and take that with radiosurgery. But you really need a microcatheter exploration, sometimes with transvenous control. Yes?
But looking at the angio, this is going to have a lot of perforators both from the it would be having a lot of thalamoperforators, both
Right.
from the anterior and the posterior circulation. So would you risk with
And
embolization?
see, the thalamoperforators are the ones will be left for the radiosurgeon to deal with.
Yeah,
Because
even with
I
the
don't
primary-
know. Honestly, we don't have a run
Yeah.
to really evaluate this. I'm just theoretically mentioning that sometimes with very large venous drainage, you can access it both ways through the really small catheters and create all kinds of interesting dynamics for embolizing it.
We have done a few. We have done a few staged radiosurgery following Pittsburgh data. The results in our hands, which is now how many years? More than 27 years. Is the occlusion rate is less than 60%. So it's not really great. You know, it's 50 to 60%. That's
I
about
agree. These are tough. Yes, Aditya.
The only other thing is a practical point. You see, in the Indian scenario, I haven't seen too many patients who are willing to 4 and 5 sessions of embolization.
I agree.
You do 1 or 2 sessions, and after that, they want
I
the
know.
last thing, choose one, and then you're done.
we have had patients.
So may I just interrupt for a moment? I'm so sorry. May I request everyone in the back to please respect the case discussions that are going on? I do understand that this is a great time to, meet with each other and greet with each other. But if you want to chat, please do move out. This is going to finish in the next 20 minutes. And then, of course, the food is going to be served. But please show the panelists and the chairperson some request. Thank you so much.
Don't worry.
Yes, go ahead.
No, staged embolization, we have a great, they have done stage, I think we have had patients, they gone on for 4 or 5 stages. He's very good, so he's very safe. So he comes out and goes back, and it's tiring also. It's not easy, and the other thing which we have realized now that there's a lot of radiation also. A lot of them lose hair, and they complain that, which was not really realized afterwards. But AVM like this, which has bled, I think you have to do it.
So again, this is we had a discussion with the radiologists, we did angiograms and all that. So in the pre-ICON era, we probably would have gone with embolization followed by radiation, and I'll come to the reason why. So we did embolization because there were some weak spots where we thought that it could have bled from there. So we did an embolization, but still the volume was significantly high because it was not a sectoral embolization. So where the ICON has an advantage over the perfection is that you can do the dose staging over a period of 3 to 4 days. You can fractionate the dose. So this patient underwent fractionated 18 grays in 3 fractions, and this was the planning. You can see that it's quite a big volume. So we decreased the dosage to 18 and divided into 3 fractions.
At what intervals? Same next day?
3 continuous days.
3 continuous.
Yeah. So, and this was at 6 months. You can already see the AVM shrinking. And this is at 1.5 years. You can see that the AVM has shrunk significantly. It has become significantly less. The next follow-up will be with the DSA, so hopefully it has shrunk further or disappeared.
That's the problem. That's the problem. You see, it's very, very promising, but ultimate complete obliteration rate is not great. It's 50 to 60% at the best.
Yeah.
We have very long, I have 3 stages. You're different, not of course, we don't have the icon, so we have staged in after 6 months actually. So, and 3 months, mostly 6 months. Maximum we have done is 3 stages at 6 months interval. And the MRA actually, the nidus is not seen. Patient has come back with bleed, DSA, angiogram, so small nidus.
And the data for hypofractionation of AVMs is really not there. There is a German series where he talks about 35 gray in 5 fractions, or 7 fractions of 5 gray to 35. And so there is some data, but we have very cautiously dipped our feet in this. What was the neurological status of this patient at this point? Okay, because the biggest risk with these large volume treatments is deficits. Yes, Manju.
Sir, before introduction of the icon, in our setting, we used to practice this dose fractionation with the frame-based one, with the perfection keeping the frame in situ, and that was usually for the 2 and 3 fractions for these volume AVMs. what we observed by the end of the 3 years, there were only some 35 to 40% patients who had a complete obliteration. But if you follow these patients in a longer duration of time, even keeping the frame in situ, it's not that discomfort as we usually perceive to the patients. And the obliteration by the end of which I am now following around 8 years, the obliteration, complete obliteration is now achieved in around 60% patients.
Yeah.
So that had been pretty safe. A few patients needed Avastin definitely with these kind of the ones, but having an option of the dose fractionation. But my question to you is, would you like to choose a volume fractionation in this setting?
So we have done volume staging. We have done catheter angio-based staging for
All
areas
of our
supply.
cases are volume staging. All our cases are volume fractionated.
Right.
None of them got full volume. It's sectorial, and we keep that and it takes a lot of time.
I mean, sir, that is an important, sir, what we used to do before the icon came was we used to do a volume staging. So we used to take the sectors and say which sector is easily available. So we used to gamma knife that, come back 6 months and do the other sector. So we used to do it. But where the icon and because of the cone beam CT has given you a flexibility is that you can actually do the dose staging now and then come back after some time and then repeat the dose also.
Doraka, both were, I mean, it's a very old concept, as old as maybe 40, 50 years. Pendle, there is a
1950,
neurosurgeon,
Johnson.
Dr. Pendle.
Pendle, before that
who
Johnson had a
visited our
series.
center actually. I mean, the full volume staging, everything is described. But whatever you do, at the end of the day, these are difficult cases.
I will show you our data, sir. And so this was our data which we just analyzed. So,
Ek second, Dr. Kale has a point.
So one more point, I remember the discussions we used to have with Professor N.K. Mishra, our neuroradiologist. And especially when we treat the young, and many of these big AVMs are young people. They are not beyond 40. It's very rare beyond 40. All these are young people in their, maybe the late teens or early 20s. And what he used to say is there are, I think I remember 2 cases definitely, where after our therapy, after gamma knife, one of the angiograms at 2 years shows nothing on the angiogram. The whole AVM is gone. And like you said, a couple of years later it comes back, patient came back with a bleed. And then you do an angiogram, you find a small AVM. And what he used to say is that AVM is an evolving process. It's a process. It's not one thing. I mean, if you see an angiogram at 1.5 years and it doesn't show, that doesn't mean anything. It doesn't mean anything. And he used to say that please get an angiogram after 4 years if you want to be sure.
so this was our data, Divya Prasad. So adult AVMs and pediatric AVMs, we had almost an equal amount of obliteration, around 75 to 80%. But the point of embolization was well raised. So in our own series, we had 46 patients of embolized AVMs, which was published, which shows a 60% obliteration rate. But considering that most of these post-embolized patients are grade 3 or mainly grade 4 and grade 5, 60% obliteration rate is actually not a bad result to achieve in them. Like I said, we just started fractionation in the last 2-3 years with the icon. So I think the data for that is still awaited. So let us see what happens.
Okay, Dwarka. I'm going to switch gears here and show something a little provocative.
The another problem is the cyst formation. The late cyst formation, very, very late. In fact, including patients who have been treated some 30 years back, they come with cysts, and that's a problem because, and I'm treating one patient right now with a cyst, and it's very big, and then we decompressed, then it came back, we put a shunt there, patient is improved, but again a new cysts are forming. So,
Okay, we'll switch gears from AVMs, and I'll throw something. Hopefully, Amal is still in the audience, because this case is really intended for radiation oncologists to look at. 52-year-old emergency room physician, colleague of mine, developed headaches, right tongue deviation, and basically showed a large mass in the skull base. So I'll show you the picture and go back to the rest of the history. Tumor debulking was done by head and neck. It's a corticotroph neuroendocrine tumor favoring PITNET. What would be the next steps in the management of this patient?
This is pre-op. What is the post-op?
Here's the post-op. Centrally cored out. Obviously, the wings of this tumor have not been really handled. And if you're wondering how much disease is left, here is the gallium-68 PET.
It's a lot of disease.
So the question is, how would we approach this?
First, number one, bad disease.
Agreed?
You cannot...
Bad disease, physician,
Yeah.
colleague, 52
you
years
cannot
old.
cure it because it's corticotroph, right?
This was a PET net, yeah.
Yeah, so it's a very bad disease. The cure rate is very low. In our practice, we don't have this icon and things like that. So this goes for SRT in our practice.
So it would go for radiotherapy,
Yes.
SRT.
Stereotactic radiotherapy.
Okay.
In my practice, this is how.
Manjul, Aditya, you have a cyber knife. Manjul has a, you have an icon.
Perfection, sir.
Perfection have you have. Okay. So you're also limited. So then we have to ask Dr. Kale, because he has.
Fractionated, do it in maybe multiple settings.
So you would consider hypofractionated gamma knife, right?
I would like to give IMRT then in my setting.
Aditya, in the cyber knife universe, send it to the LINAC or keep it on the cyber knife?
I think I would still favor radiation as a safer option.
Okay, so everyone agrees the next step is radiation. The question is how to give it. And so this same problem comes back again and again. Is this too big? And absolutely for the old planning system, till this latest version that you now have here, Sandeep, till prior to that, it was not possible for treating such a large tumor except by making sub-volumes. And in fact, when we treated this patient, we had this patient get a proton consult. They ran a plan for me. I had a LINAC planning done, which is really done by the best planner I have, and we did gamma knife planning as well. So I'll show you what the dose spillage looks like. This is the plan with the gamma, and here is the plan, this is the plan with the LINAC, and you can still see green going out fairly far and wide, and here is the gamma knife plan. Same dose cloud distribution, so you keep the colors the same, and you suddenly see how much tighter it got. So we ended up hypofractionating it 5 fractions with the icon/Esprit using a mask. And I sent these plans back out to my colleagues to make sure everyone had paid attention. He was not just an emergency room doctor, his brother-in-law is a radiation oncologist. So this was like, the only thing missing in the family was a lawyer. That would have really given me a hard time.
What happened? What happened?
Okay, I'll show you the end result of that. So this is showing you how we broke it into 4 parts. Now, Sandeep, you don't have to do that. With the Esprit software, you can treat any size. It splits it internally, as we did for the chordoma case the other day. And so we made one plan, and here's a comparison to show you the dosimetric advantage. And here he is 6 months later. Tongue deviation is gone. He's working full-time and also performing better, and his hot potato voice is gone.
Hormones. What's the hormones?
Okay. Well, he was already replacing because he had this big tumor. So he was already
But it's a
replacing one of the
corticotroph.
hormones.
It's
so
a
now
caustic
yes, the hormone levels have come down, but not totally down to normal. He doesn't secrete a lot. It's a weird one because it's not an active hormone.
No. The diagnosis, I would like to know the diagnosis. Is it the histological immunohistochemistry diagnosis of corticotroph, or is it the hormone producing corticotroph?
No, it's a IHC diagnosis of a corticotroph.
That's different. That's different.
It's a lot more.
If it is a high cortisol producing corticotrophic,
much more
they
risky.
all fail. This is all failed. Okay. But if it is an immunohistochemistry diagnosis, that's a different thing. I mean, they part of the tumor is only producing it. So that's okay.
And Dr. Raina, question for you is, we were given some indication that temozolomide may have a role in this tumor. And I wondered if you've had the chance to use that.
Temozolomide has a role in some neuroendocrine tumors. We do use it in some neuroendocrine tumors, either sometimes low grade or even high grade when the chemotherapy has not worked. I think the efficacy of temozolomide is about 20% in these neuroendocrine tumors, nothing much more than that. It doesn't work in high grade tumors so much.
I had a question for you. What is the difference between the proton therapy plan and the gamma knife plan?
Actually, the proton therapy plan was worse for the same reasons I showed you from the selectivity point of view. In this position, it was all about containing the dose in there. And I literally sent my parameters back to them with their plan and said, you tell me which one you would pick. And it was, of course, MD Anderson, they have a gamma knife, and their questions were all about how we planned it, how we managed to get this whole thing done. And it took a long time. The optimization used to take overnight. So don't be disheartened. The Chordoma case was taking on your computer about 30 minutes to optimize. This ran overnight, just so you know. So, and really I was showing this for Amal to see that there are things you can do that seem like you're a cowboy, but it's the best solution for the patient. He's doing great.
The common protocol we use is capecitabine and temozolomide. Captem is the combination.
And that was what he was recommended as well, and he's on that too, and the tolerance is very good. We won't put up a case. We have about 10 minutes left. Just polling
the non-functional pituitary adenomas, non-functionals, also have reports of responding to temozolomide. We have tried some of these cases completely. I mean, there's nothing else we can offer, and few cases they're still being managed by temozolomide, and they have responded. But this is anecdotal.
Well, we threw everything, including the kitchen sink, at him because this was our chance. Nobody can resect it. It's got to be managed by other means. I was just demonstrating that you can use a tool designed for small targets. People often criticize and say gamma knife is only for small targets. Actually, the dose quality is maintained over large targets too. You just have to hypofractionate. Across the panel, let's talk about large vestibular schwannoma, partial resection, and radiosurgery. What are your thoughts? Starting with Sandeep. I know Rana will take the whole tumor out, so I'm not asking him. And Dr. Mehta will take the whole tumor out too. But let's say, what do you think?
It depends on how much is residual.
So we're talking about a tumor that is fairly sizable. I would say 35, 40 cc, symptomatic. And you're going in and you're using stimulation and monitoring as you're operating, and you're getting to the end of the rind of the tumor and you start to see the facial response. So do you have your own metric to stop and do radiosurgery, or do you keep going? What's your usual? And I know because you like to reanimate the facial nerve, so that's why I started with you.
So I would like to keep on going till I can remove it, almost all of it, maybe leave a little bit around the facial nerve, but that's it.
Okay.
I would prefer to remove most of it.
So you would still like to go for broke? You would not electively say, this is too big, I'm going to do a subtotal.
See, when you try to do that electively, you end up leaving a lot more tumor than you anticipate.
That's actually a very valid point. I think Roy Daniels makes the point from Lausanne about planning and removing it. In fact, BrainLab has software that lets you intraoperatively assess what you've left. If you do an intraop measurement and MRI, and tells you what your radiosurgery plan will look like. Manmohan, what's your thought on this?
I think I agree with Dr. Sandeep. Most of the tumors which we see in our current practice, so that the large tumors, so many times the facial nerve is very, very thin, and it is very difficult to dissect it off. So I would definitely like to leave a sleeve of tumor along the 7th nerve and come back with the post-op SRS.
Okay, all right. Aditya.
See, my approach is that it depends on what you call as a good decompression. Just pouring it from the inside and coming out saying that we'll give radiosurgery to the rest is actually you land up with a tumor which still looks very large. So my personal approach is you go for both the poles of the tumor and then you deliver the tumor laterally so that you're releasing the pressure from the cerebellum. At the end of it, I would say if you're leaving behind something like 20% or 30% of the tumor, and you have these anatomic cues to tell you that you have created a lot of space in there, I think that to me, coupled with the stimulation, is the point at which I would stop and think of radiosurgery.
Manjul?
Sir, I go in a very custom-tailored approach in these cases. First, how should you define a large vestibular schwannoma? Supposedly you take it as a Coos grade 4, then I would like to take into consideration the age and the symptomatology of that patient. If the presentation is with intractable trigeminal neuralgia or something like that, I would straight away go with surgery. I wouldn't consider radiosurgery, primary radiosurgery in those cases. And if the patient is on the older age size, when I need to take into consideration of the cerebellar atrophy as well, because even despite having that much size, the patient might not be symptomatic. There might be a radiological compression of the middle cerebral peduncle, but the patient is completely fine. Then I would consider the primary radiosurgery in those cases as well. But if the patient is the younger one, then I would like to go with a planned partial resection, waiting for 6 months to 12 months, depending on the post-operative facial nerve status. Then I would subject this patient proactively with the secondary radiosurgery in those cases. And
so that's a great point you raised. I totally agree with you. There is a population of older, somewhat more roomy brains where a large tumor is not quite as large a tumor. Its volume is not the only characteristic. But would you consider hypofractionation?
No, I wouldn't. I do not find any benefit of giving hypofractionation in the vestibular trauma.
Manjul is a die-hard gamma knife.
And sir, we recently published this with the International Radiosurgery Research Foundation, and then we dichotomized that data in the different age groups, and we found that the 7-year tumor control rate was more than 85% in those patients who were primarily whose grade 4 received primary radiosurgery, and they were fine. So I think we need to follow these patients for a longer duration of time, but for the short duration, we are secure.
Now, Basant, I have a different question for you, because you and I have shared this podium before, and you used to always show these large tumors and say, in India, the acoustic data with radiosurgery is not relevant. So what do you think today?
No, I mean, fortunately, I decide which patient will go to radiosurgery. That's very important. I think that's the beauty of gamma knife is the neurosurgeon decides, because he knows what he can do. What we do is the large tumors in elderly people, many of them don't need treatment, number one. It's not necessary, like the patient is asymptomatic, you pick up a tumor, you don't need to treat, because many of them are just burnt out tumors, and we have a number of patients, and some of them present with NPH. They just need a shunt, and we have a number of patients with just a shunt, nothing to the tumor, and patient is asymptomatic. So number one. Number two, I do not like Sandeep. I would go like tumor to take it out, but my the approach had changed obviously over a period of years, because we are much more focused on functional preservation. So if at any stage we think that the function is going to be compromised, I don't hesitate to come out. But I do not go with the concept that you have a subtotal excision, elective gamma knife. No, I don't agree with that. And it's an more American concept now rather than otherwise. Yeah. I would do that. And if I leave a thin sliver of tumor like Aditya said, I don't need to rush, because many of these do not need treatment. We need to follow up. The problem is when the follow-up is suspect. Then there's a problem. In our country, they will come back with a big tumor again.
I agree.
So that is
I
the
agree.
problem.
It's a hard task for me to convince Siddiqui to leave any tumor behind. So I can tell you right now, there is still a big case. Dr. Kale, what is your viewpoint at AIMS now?
No, I agree. I mean, you have to try and remove the tumor as much as you can. But how much to remove? I mean, that is the key.
So with good monitoring, if you hit a point where your capsule is not dissectable, you would stop.
Yeah. So one question I have, again for you or my panelists. A few years ago, Brain Lab had introduced us to that gamma plan inside the brain suit operating theater, which let you do an MRI intraoperatively and tell you whether this is fitting into the gamma plan or not.
Exactly.
But I haven't seen any data come out of that.
Well, mostly because the technique fell on deaf ears. Most surgeons said, I don't need a scan to tell me how much I can take out. I know what I can take out. So that's why this is a great lineup of people telling me exactly that. I'll make the decision in the OR. What do you think?
So, in Bangalore, where I practice, I remove the tumor totally. If a thin sliver of tumor is kept, we observe, and we don't irradiate immediately. Very elderly, I'm saying very elderly meaning for acoustic above 70 or 75 years, we observe. If the tumor is only growing, then we offer decompression, because we don't want long course of surgery, and then post-op radiation if necessary. So,
so you will leave a sliver, but not necessarily jump to radiosurgery.
Yeah, most times we take it out.
Because generally they wait about 6 months anyway.
Yeah.
So, but you could wait longer and prove growth before going at it. Because once it's devascularized, it may sometimes not grow for a long period of time.
So I just give you some data. I mean, one of my resident analyzed out of 1,017 odd cases, microsurgery done by me, 17% went for gamma knife. So that's the data, that's hard data. Okay? So 83% did not have radiosurgery for
And fair enough, in a cost-conscious situation and in terms of serving the patient, the only guarantee, as you said, or somebody mentioned, is follow-up. If you can guarantee MRI follow-up, then it's a reasonable strategy. If you're concerned about losing the patient for years, and they're young enough, maybe elective radiosurgery done at about 6 months should be the plan.
So two things. One is, if you follow the principles of surgery, opening the internal acoustic, drilling the meatus, and taking out, I don't see any reason why we should be leaving much of the tumor. But having said that, we also published a study from NIMHANS on gamma knife for large vestibular schwannomas above 10 cc. And the tumor and the results were very good. The long-term tumor control rate was 86%. Facial nerve preservation rate was 96%. So, I mean, you could argue it out both ways as to whether surgery is better or gamma knife is better, but there is evidence to support both. If you're operating it, if you follow the principles of surgery, you should be able to do a very good job. But if you want to give gamma knife, like for what reasons Manjul said, gamma knife also gives you good results.
Final question, on a completely different topic. Yes or no, do you think tremor thalamotomy performed by a radiation oncologist using a linear accelerator without a neurologist or neurosurgeon present is appropriate management of the patient?
Definitely not.
And Mohan?
Not.
Certainly not.
Certainly no. Vasant? You agree?
And not only for the tremor, for practically any functional ailment.
Trigeminal is a close follow-up to that, but what alarms me more than anything else, not here, I'm not talking just here in India, I'm talking in the US too. There is a whole concept of pushed by one company that you can use your LINAC to do tremor thalamotomy. These are the coordinates. I'm pretty sure functional neurosurgeons in this room will agree. Even when we know the coordinates, we think 100 times. When we put a DBS, it's one of the most stressful procedures you do because you're not guaranteed you'll get the result, and the drastic side effects could be tremendous. At least you can turn that off. Radiosurgery is a permanent event, and I am alarmed by the trend. So for all of you doing radiosurgery, educating the neurology community is very critical. Those patients belong in a neurology, neurosurgery joint management practice. And if radiosurgery has to be done, the team has to be there with the patient, not an isolated person with a tool making holes in the brain. I think that's a very dangerous international trend, and it's being pushed by one company, and it's really a terrible idea. The associations should talk about it. Neurology Society of India should take it up. It should be actually regulated before it becomes a real problem. I think we'll close this session here on time. Okay. Thank you, panelists. I think we need another picture.
This is going to make a lot of people very happy. We're now almost at the culmination of our launch event today. But that means we still have to launch something. It is time for the grand unveiling of the Gamma Knife Esprit. This state-of-the-art technology, okay, let's get the pictures done. Thank you once again. The Gamma Knife Esprit is a state-of-the-art technology which is set to revolutionize the way we approach neurosurgery and radiation therapy. Let's see how.
Introducing a cutting-edge innovation in the landscape of neurosurgery, the Gamma Knife Esprit, now available at Fortis Hospital, Gurugram, marks a revolutionary leap forward in brain tumor treatment. This state-of-the-art technology utilizes precise, non-invasive radiation to target brain tumors with unparalleled accuracy. Our team of expert neurosurgeons at Fortis Hospital, Gurugram harnesses the power of the Gamma Knife Esprit to provide patients with a safer, more effective alternative to traditional brain surgery. With a non-surgical approach, patients benefit from a pain-free experience and reduced radiation exposure, ensuring patient-focused care. The Gamma Knife Esprit also shortens treatment duration, making it a convenient outpatient procedure. With its advanced capabilities and unmatched precision, the Gamma Knife Esprit offers hope to patients facing challenging brain tumors. Experience the future of brain tumor treatment at Fortis Hospital, Gurugram.
Very quickly now, I would like to, thank you. I'd like to invite to the front Dr. Rana Patil, Dr. Sandeep Vesh, Mr. Anil Vinayak, and Dr. Bishnu Panigrai, please. And Dr. Mehta. So in their hands is something through which we will launch what we want to launch, and you are going to press the button when I say now. Doctors, you're going to press the button when I say now. So are you ready? Yes, you are. At the console, are we ready? All right then, now. And before we all move out, a vote of thanks by Dr. Rana Patil.
I would like to thank our chief guests, Professor Banerjee and Professor Dr. Mehta, for gracing this occasion. Then I would like to thank Anil Vinayak and the organization, the Fortis organization, for all the help and the bringing this whole Gamma Knife thing together. I would like to thank Dhirendra Prasad for his erudite talk and his excellent management of the panel discussions. I thank all the panelists, from which we derived a lot of knowledge. Of course, I thank the audience for having given us this time today and come for this occasion. And lastly, but not the least, I would like to thank my good friend and colleague Sandeep for his great attention to details and his excellent organizational skills, which made all this happen. Thank you very much.
The bar is open and dinner is served. Thank you so much.